Welcome to the 2023 UT Southwestern Kidney Transplant Symposium. Thanks for joining us today. So first of all, I'm Scott Bennett. I'm the Associate Vice President of Solid Organ Transplant here at UT Southwestern. As I said, I'd like to first thank our in-person crowd here, our live studio audience, if you will. Thanks for joining us today. Give yourself another round of applause. And then, of course, through the miracle of modern technology, we have almost 200 so far that are joining us over Zoom. So thank you for joining us via Zoom. And as a reminder, this is an interactive presentation. You will be on mute. I will remind you of that. But you will be allowed to interact with our team, ask questions, etc., as the presentation proceeds. So again, thanks everyone for joining us today. The presentation will be provided afterwards, so don't worry if you miss something. As it relates to our CE credits, here's our disclosure for our learners today. UT Southwestern Medical Center is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. Rolls right off the tongue. So, as you probably know, this activity does provide 5 contact hours, which I know you're all excited about. The other thing I'm excited about, though, is our sponsors for today. So, I'd like to especially recognize CareDx, MedSleuth, Natera, Sanofi, and Veloxis Pharmaceuticals. Thanks for joining us today, and thanks for your support. We really appreciate it. As I mentioned, today's presentation is interactive, so you will have the ability to ask questions to our transplant team. I will ask you to do this QR code right now because this will allow you to access the link that will enable you to ask questions. So if you click this link there at the bottom of the agenda, then you'll be able to ask questions. You'll see a little drop down that shows what presentation we're talking about or what presentation you specifically have a question about. And you can type that question in, and we'll facilitate those questions at the end of each presentation. So if you haven't already, grab that QR code on your phone and keep that handy throughout today's presentation. So without any further ado, let me start off with today's first presenter. That would be yours truly. I'll go ahead with our first presentation. I want to talk a little bit about transplant access. So anyone who's traveled to a major U.S. city has probably stared at a map like this blankly as they try to take on public transportation, right? This one looks particularly scary, to be honest. This one is meant to represent the U.S. transplant system. So this was done by our friends at the SRTR. That's the Scientific Registry for Transplant Recipients, or the group that's charged with reporting on transplant outcomes. For those of you who know the SRTR, they don't have a real gift for making things simple. I'll put it that way. And this is no exception. So this map was meant to answer the questions of who, why, what, and how of the U.S. transplant system. And you see it goes actually from item A all the way to item X at the bottom right. So the point of this is put yourself in that far left-hand side of this map there where the patient is. It's got to feel pretty daunting, right? And they have to feel just like we do as we stare at that foreign, whether we're in Chicago or New York or wherever it may be, looking at that map going, oh my gosh, where do I go next? But that's not all the complexity that resides in our system. Unfortunately, that track is smoother for some than others. What's not shown on the map is there's an unintended level of complexity that's driven by disparities. So for example, Black and Asian Americans are less likely to register to become organ donors. Black patients are less likely than white patients to be preemptively referred for transplant. Older patients and female patients on hemodialysis are less likely to have discussions about transplant with medical professionals. And Black patients were almost 60% less likely than white patients to receive a living donor kidney. So these discrepancies, of course, aren't intentional, but nevertheless, they do exist. So what do we want to do? We want to promote equity to access and transplant. So differing from equality, equity seeks to provide opportunities needed for individuals to reach an equal outcome. So just to be very blunt about this, equality would be giving everyone in this picture an equal sized box. Equity is allowing them, as it is in this picture, equal access to the apples on the tree. So as you can probably gather, the apples on the tree are transplant in this case, and we want to provide equity and access. There's a number of factors, both biological and sociological, that can contribute to a patient's access to transplant that are listed below. So we measured this, like we measure just about everything else in transplant, and we look at these factors that contribute to the access to transplant. So those factors that I mentioned before, combined with a deceased donor's access to transplant, creates an ATS score, an access to transplant score. And if you go back to statistics class with me really fast, I'm gonna hit on standard deviation. So standard deviation on the left is the variability from the mean. So what we want when we look at our ATS is a tight standard variation, as we see on the right-hand side. That tells us we're improving equity to access. A couple of the items that contribute to equity most prominently are DSA, or donation service area. That's basically your patient's geographic location. So what's that? Population of the area they live in, the performance of the OPO in that area, those contribute to access to transplant. CPRA, of course, a person's immunological response. Blood type, patients with type B or type O have a reduced access to transplant, as do people with prior kidney transplants as well. But are we making any progress? So I'm happy to report that we are. If you look at this over the last decade or so, there's several milestones that show an improved access. So what we want to see here is a lowering score of ATS, as we talked about earlier. So if you look at that first star, that was the implementation of CAS. And the major victory with CAS, you see a pretty big decrease there, was equal access for those with higher PRAs. We were really able to level the playing field there. And then as we go on, we start to level the playing field with people due to geography, and then most recently with the elimination of the use of race-inclusive EGFRs has also been a big step for us. So good progress is being made by the transplant community as it relates to access. I found this study really interesting, though, because at the end of the day, what do we all want? We want access to transplant for our patients, but how badly do they want it is something that I was interested in. If you look at the highlighted box in red, this shows that the average respondent would accept a kidney today with 6.5 years of expected graft survival to avoid waiting 2 additional years for a kidney with 11 years. So this quantified things for me. They want access to transplant, and they want it now. And I think that aligns with what we're trying to accomplish today in today's session. So like I said, we're all trying to accomplish the same thing in this room, and that's to promote the gift of life. And we're very grateful to have you as partners in the care of these patients to provide that precious gift. So without any further ado, I'm going to introduce our moderator for today's session, Yvonne Ford. So Yvonne comes to us from the dialysis community. She's been with us for several years now. She came to us actually during the time of COVID, which made her job as a social butterfly very difficult. But now that she's able to traverse out and about, I know you've seen her in the dialysis centers, both here and in Lubbock and in Tyler, all the way across the state. So she does a fantastic job of promoting not only our program, but access to transplant due to her passion for this population. So thanks so much, Yvonne.
So good morning. Okay, let's try it again. Good morning. Good morning, Zoom participants. I'm Yvonne Ford. I'm so excited to be here today as your moderator. It's great to be here. We have over 400 participants today, in person and via Zoom, so give yourselves a hand. Now, I know some of you made your way through that traffic this morning, and I applaud you because I did the exact same thing. So for those of you in person, I want to say a great big hello and welcome to our facilities. Welcome to our hospital. Glad to have you here. Glad you're out of your office. How many of you happy to be out of your office today? Exactly. So we are serving patients. We have individuals out of state attending. Our Tyler and Lubbock satellite clinics are attending virtually. So I'm excited about that. And let's move into some business. So remember the questions. You saw the QR code for questions. Please remember, as each speaker is speaking, please take your questions, submit them at that time. And I'll be getting the questions over here on my end. It's a little bit different than the chat from last year. So I'm excited about that because we're going to be able to track it a little bit better. We've allotted time for questions, but if we start running out of time, we're really, really specifically focused on your time today. We appreciate your time, but we want to get you out of here on time also because traffic in the afternoon can be bad. Y'all agree? Exactly. So if we don't get to some questions, they will be answered. There will be no question left behind. All right, so let's go ahead and introduce our very first speaker. I'm so excited to introduce Helen this morning. Her name is Helen Bankston. She's our lead transplant intake coordinator. When I started back in 2020, she trained me, and don't hold it against her, but yeah, she trained me. And everyone always gets us confused because she was here before me, and they keep getting us confused. And now that we can go into clinics and talk to patients and staff, they're starting to understand that I'm not Helen. So when I introduce myself at the clinics, they're like, oh, Helen is here. I'm like, no, I'm not Helen, I'm Yvonne. So I'm like, when I point myself out on our pictures, you can see our pictures, we look a lot different, than each other. So I always say, I'm not Helen, I'm Yvonne. So we'll have Helen. Let's welcome Helen up to the podium.
Good morning, everyone. Thank you for being here. We're so excited to have you. As Yvonne said, I'm Helen Bankston. I'm the referral intake coordinator for the kidney transplant program. I'm going to go over kind of the intake referral process, how to get started, who to contact, who to refer. So I'll put my number up here. Feel free to call me directly. This just calls my cell phone, and I can navigate any questions you have. I'm going to talk a lot about our online referral portal that we're excited about. I have a few slides on that next, but I wanted to be sure to put the website up there. Southwestern transplantreferrals.org. You can go on there. We do still accept fax referrals, but we really do encourage the online portal to optimize the referral management. So who to refer? Patients on dialysis obviously would be eligible, assuming they meet our criteria. And then patients not on dialysis yet, CKD practices, if the GFR is 20 or less, they meet criteria to do an evaluation. And then once we get the referral, our goal is to contact the patient and within 24 hours to get the appointment set up. So we'll reach out to them pretty quick. So MedSleuth is our online referral portal. There's just a few easy steps to kind of get that referral placed. I do encourage you to set up a username and password. Once you go to the website, you can register an account. You are able to do a one-time kind of guest referral, but there is a function to see all your referrals in one spot, and that's why we're really pushing the central referral management. So if you create an account, there's a tab where you can see all your referrals and the status. So we really encourage you doing that. And then once you log on, there's a button to submit a referral, and you'll enter the patient's demographics, referral information. There will be some screening questions, and then the last page will be where you upload the referral documents and then submit. So it's a pretty quick process. I do have some screenshots that I'll show you to kind of walk you through it. So we're hoping this will be a streamlined referral process for you and us to improve efficiency all around. And then I mentioned that centralized referral management. So when you log on, you can see all your referrals in one spot and kind of see the status. It is a web-based platform, so nephrology practices, dialysis centers, anybody with the internet from a provider can put in the office. You don't have to have a special app or anything, so that makes it easy. And then another benefit would be just the convenient management of communication between the referring providers and then the transplant center being us. So here are some screenshots. So the first section is demographics, so name, address, phone number. It'll ask you for the nephrologist who's referring, the dialysis center, just basic information there. And then the next page will be the screening questions. So I'll talk more in depth about the eligibility criteria in a little bit, but this is just kind of showing you it's just yes, no questions. Are they on continuous oxygen? Do they live in a nursing home? Are you being treated with chemo? Those are absolute rule outs. So if you do answer yes to one of these questions, you will get an automatic response, which is another benefit. You'll get a, thank you for your referral. Unfortunately, you don't meet our criteria, or the patient doesn't meet criteria. You don't have to go to the next slides and upload records and do all those next steps. You'll get an answer right away. So that's a big benefit. I did want to point out too, on the bottom right, there's a previous button. I have gotten some feedback that once you get in there, you can't go back to the previous page. You should be able to just hit previous and go back if you need to review the information before you submit. And then this is the upload page. So we do request that you upload the 2728, the last MD nephrology note, most recent labs, and the insurance card. Upload files and then hit submit. And then we get the referral. So there's just a few pages to work through, and hopefully it's pretty seamless for you guys. So I mentioned the eligibility criteria. So this is those screening questions. So you put in the height and weight, it will automatically calculate the BMI. So that's an absolute rule out. And patients too, if you fax it in, we're still doing those questions. So even if it's not going through MedSleuth, once we get the referral, that when the scheduler calls, they'll ask those questions. So if they do answer yes to one of those questions, they will send me the message. And still, instead of getting the automatic response, I'll call you and let you know they're out of our criteria and they won't get scheduled. So those criteria would be BMI over 45 or less than 16, requiring continuous home oxygen, nursing home residents, patients currently being treated with chemo or cancer therapy, open wounds requiring treatment, severe dementia, or if a patient is unable to walk independently, so that means no walker, no wheelchair, that's kind of to assess their frailty. That's a big requirement for a transplant. Patients that answer yes to that will not get an appointment, and we won't move forward. They're outside of our criteria. The next section, the relative contraindication. So these are patients that aren't an absolute rule out, that you answer no to all of those, but they still have some high-risk criteria that may make them ineligible. So patients over 75 or older with amputations, peripheral vascular disease, active smoking, taking midodrine for blood pressure control, or cancer within 3 years. So those patients still get an appointment. We've started doing a screening visit. So they will come in and see our provider. And instead of doing education and labs and social work and all those other visits, it's just a screening visit. So we'll kind of meet with them and we'll determine at that point if they're eligible to move forward. If not, we'll go ahead and eliminate those appointments, the additional appointments, and we'll close the referral there and obviously let you know. But these patients, the point of that is to kind of get your committee decision quicker, get that outcome quicker, instead of having them jump through those additional hoops when we know up front it's a little high risk. We can kind of get that answer quicker without going through the extra steps. And again, that's kind of what the bottom is saying. Our goal is to improve overall access and get a quicker decision on the high-risk referrals. So this graph is showing that patients live longer with transplant than being on dialysis. So this is why we're here. This is why we do what we do. The data speaks for itself. We are here to get your patients transplanted so they can live a longer, healthier life off dialysis. So when in doubt, send us the referral. If you have any questions about, insurance or do they have support? I don't know. It looks a little squishy. Just send it in. We'll sort out all those details. Don't worry about that, and we'll take it from there. I've listed my number again. Feel free to call me directly if you have that. That calls me right to my cell phone. And then we do have this UT Southwestern kidney email address. Feel free to shoot us an email. Myself or Yvonne, we both monitor that inbox. So we'll get back with you if you have any questions. And then, we're here to help. So reach out. So thank you. We're so glad you're here. We hope you enjoy the rest of the program. And I guess we're doing questions now if you have any questions.
Thank you, Helen.
Thank you.
Okay, Helen, we have 2 questions so far. So thank you all for using the QR code to submit your questions. The first question came in. It says, how long does the process take for a CKD patient to be scheduled for the first transplant visit?
So we're usually about 6 weeks, 4 to 6 weeks out, really driven by provider availability and getting patients in. We'll call you again, we contact you within 24 hours, but it's not just CKD patient, any patient. We don't kind of do dialysis patients versus CKD, but it's about at least 6 weeks out.
Okay, thank you. Next question, please define independently walk on the referral page as pertaining to using a cane or walker.
So independently with no cane or walker or wheelchair. They have to be able to walk roughly 1 block without any assistive device, so totally independently.
So if they're holding their cane in their hand like this and walking, does that count?
I would say so, if they're not using it for support.
Okay.
And to explain the reasoning on that, it's a kind of a frailty assessment. If someone is that frail and weak and don't have the strength, statistically, they don't do well after transplant. So it's kind of an assessment of post-transplant success.
Okay. Next question, if the patient lives in a different state but may have to do the initial screening prior to being able to schedule evaluations, meetings with surgeons, financials, et cetera, are they able to do that stuff virtually?
No, we do see the first visit in person. We do have patients coming from out of state, but they do need to come in person.
Okay. Next question, can the over 75 contraindication pre-screen appointment be completed at a satellite clinic? Would this happen on a day separate from the kidney clinic days?
We do have set days, but we do have satellite clinics in Lubbock and Tyler. So yes, the initial screening visit can be done there. They don't have to come to Dallas. And in those locations, the full eval is done there. So if they do their screening visit or Lubbock and Tyler and they say, okay, yes, you kind of were in the high risk criteria, but you look pretty great and we think you'd be a good candidate, let's go ahead and do the full eval. The rest of those appointments are also done in the satellite locations. So for Lubbock and Tyler, ideally the goal is that everything is done there locally. The transplant is physically done in Dallas, the surgery, and then once they're discharged, all the follow-ups are done in the satellite locations as well. So ideally just the surgeries here.
Okay. And for the out-of-state, one more clarification. Out-of-state patients, once they come in for that initial visit, would subsequent visits be telehealth, or would they still continue to come in for every single visit out of state?
So we can do the education telehealth, and Laura, correct me if I'm wrong, do we do some social work telehealth, or does that?
We do as long as they're
In state.
Right.
Yeah, and good point to that. So the reason of being too, you asked about the screening visit, they have to be in state because that has to do with physician licensing, and they have to be licensed, and the patient has to physically be here because of licensing. If someone is in California, we technically can't treat them there because we don't have California privileges. So for the provider, they do have to be physically here. So yeah, to Laura's point, they have to be local. Can we do education remote? But I guess no? Cheryl's saying no. But when you're coming anyway,
Yeah.
so say you're coming from California, we'll try to schedule those appointments on the same day so you can get everything done together. So it's not, each appointment isn't a separate trip. We'll work with you and coordinate those visits, but does that answer the question?
So next question, can we refer a patient who is undocumented?
So that is a very good question. They do have to be documented. They do not have to be a citizen. They have to be a legal resident, have some kind of documentation, can't be completely undocumented, but they do not have to be a citizen.
And it's more about long-term access to healthcare. If they're, you don't want them to end up in a position where they end up having to go home and they don't have access.
Right, yeah, if we give someone a transplant and then somehow they get deported or something legally comes up, how do we protect that organ? We don't have access to them to take care of them, yeah.
Okay. That's it for the questions, guys.
Those are good
Thank you
questions.
for
Okay.
submitting
Thank
those
you.
questions, and thank you, Helen. Let's give Helen another round of applause. Thank you. Okay, so y'all weren't shy sending in those questions. That makes me happy. Our next speaker this morning is one that our transplant program is truly founded on, and that's Miss Laura Restall. She's our lead kidney transplant coordinator. So when you all send me those very difficult questions, I'm usually CCing Laura or Helen to get those answers. But Laura has most of the answers for every question that you have. So as she's So as she's speaking, please don't forget to submit your questions, so we'll have them at the end. But you all, let's give a warm welcome to Miss Laura Restall.
Hello, all. I'm Laura Restall. I'm the lead kidney transplant coordinator, and I welcome all of you here today. My role in this process is kind of give you an overview of what is it like when the patient does enter the system. That's everything from their evaluation, when they go to selection, when they're actually placed on the wait list, where we notify you as well, and when they're called in for transplant, the surgery itself, and then the follow-up care involved. So how do we do our evaluations? Our goal is to get a patient through the evaluation within 30 days of being seen. So how do we do that? We do it as a one-day evaluation. We have them come in and they see a nephrologist, they see a transplant coordinator, they see a social worker, and they get some baseline labs. So those patients who have less than 3 years of dialysis, they're not going to be called today for transplant. So our goal is get them listed so they can start accruing the time they need to get closer to transplant. It's also a really nice thing for insurance companies that we don't repeat a stress test every year, knowing that they're not going to get called for transplant before that time frame. If they are, we would perform some of that those tests on admission. If the patients have tests done elsewhere, we can get copies of that testing and we can apply it towards their evaluation. So less than 4 years of dialysis, they're just getting a baseline assessment. Yes, they meet our basic criteria to move forward with transplant wait listing. Some of the factors to consider, and I know Helen touched on those, cardiac disease. The reason why cardiac disease is a huge thing is because if somebody has, say they have a blockage that hasn't been cleared, the stress of surgery itself could cause a complication. So we'd want to address that before we move forward. Malignancies, even recent malignancies. You know how a lot of breast cancer survivors will say, once I hit 5 years of no recurrence, I'm probably out of the woods. We require those same clearances because if you've got a cancer cell hanging out at the time of transplant, it could go everywhere post because we've suppressed your immune system. Functional status. I know Helen talked about functional status. It's kind of a controversial thing. So if someone had a spinal cord injury, for example, and they were using a wheelchair, but they're functional, it's a spinal cord injury, we can move forward. But for that patient who's reliant, say you're probably familiar with a patient who recently had a stroke. They are dependent on maybe a walker or a wheelchair. We call that, and the way we explain it to patients is, you're about to face the 12-mile bridge, and your gas tank is only half full, right? And the sign is saying, make sure your tank is full before you get on this bridge, because if you run out of gas, there's going to be a problem. Well, with those patients, we want to ensure that they have the reserve to recover. So a lot of times what we'll tell them is, let's get you into physical therapy. Let's get you to that point where you're strong enough to move forward with transplant, and a minor complication will not take over for you. Autoimmune disorders. So you're familiar with the lupus population or the IgA population, the FSGS population. We want to make sure that those autoimmune diseases are quiet before we move forward with transplant, because if they're still active, it's going to take over that new kidney transplant. Liver disease, as you know, if they've got severe liver disease, they may be a candidate for combined organ transplant. BMI, of course, BMI, we all struggle with the BMI. From 40 or less, we can move forward. We also offer referrals to weight wellness and bariatrics. So we will see people who have BMIs up to 45, so we can go through and get them started with a program that will help them get to a healthy weight. Active infection, it's just an immune system. If the infection isn't clear before, the infection's going to go everywhere post-transplant. Open wounds kind of falls in that infection issue. The wound won't heal if you're immunosuppressed. Support is a huge one. We want to make sure that the support understands their role in this process, because we've had patients, they come and the patient's family said, I had no idea that I needed to give them a ride to their appointments. I just knew I was going to be available when they were called for transplant. So we want to ensure that maybe one or two people are available so that we can move forward with that evaluation, and we know that they'll be taken care of post-transplant. Adherence is a big one. If they're not adherent pre-transplant, they're not going to be adherent post-transplant. They're just not going to be successful. Substance abuse and active nicotine abuse. Substance abuse kind of falls in that category. It's going to cause complications post-transplant. Active nicotine use puts you at a higher risk for cancer post-transplant, and it also can put you at risk for respiratory issues at the time of transplant. So we require a 6-month nicotine-free period prior to waitlisting. BMI and transplant. BMI is greater than 40. It's a complex surgery. Often it's more complex at the time of surgery itself. It probably will take longer. Wound issues become an issue post-transplant. Infection becomes an issue. Even wounds opening up post-transplant. So we recommend BMIs 35 to 40. We will offer referrals to Weight Wellness and to our bariatrics program to help get them to that healthy weight. Once their evaluation is done, what we will do is we will take them to our kidney selection committee. This is multidisciplinary. Surgeons, nephrologists, social workers, dietitians, finance, they're all looking at that person's case to make sure that it's safe to move forward with transplant. The first option is approved, no further testing needed. At that point, you get a phone call saying, hey, Mr. So-and-so has been approved. We're going to get him waitlisted for transplant. The second option is deferred. What it means, someone sees something in that evaluation they feel needs additional exploration. So at that point, you're going to get a call and saying, you know what, they're not closed. We just need to look at this one issue before we move forward with transplant. At that point, the appropriate test or the schedule will be set up and the testing will be done, and we'll represent them to committee for approval. The third option is, unfortunately, transplant is high risk for that candidate. At that point, we'll explain that to the patient and we'll explain it to the dialysis unit. What I will tell you is our providers are excellent at patients who do not meet criteria for transplant. They tell them during the visit, these are my concerns. These are the things that I think you should work on prior to moving forward. So placing a patient on the wait list. So kidney transplant, it's based on a variety of factors from wait time to donor acceptance. Dialysis time, if your patient started dialysis in 2015, they're going to get accrue time from 2015 moving forward. So they'll have quite a few years of wait time when they get waitlisted. Doesn't matter if they're waitlisted today. Average wait time is 4 to 6 years. So we definitely encourage living donor, and we also encourage accepting more than your standard criteria donor. Active means the patient's ready for transplant. Inactive means could be for a variety of reasons. Either they were hospitalized recently. We want to give them time to recover, so they're not eligible for transplant right now. Non-adherence. We've gotten calls from dialysis unit social workers or charge nurses, and they're going, I just want you to know he hasn't shown up for the last 2 treatments. I think you guys should be aware of this. At that point, we meet with the patient and we talk to him about the fact that we need to achieve 6 months of adherence to move forward with transplant, because he or she won't be successful. Inability to contact. You're going to hear this as a theme throughout this presentation, because that inability to contact could prevent transplant. They could miss an offer. What if they haven't reached readiness yet? So we don't forget about these patients. They're waitlisted, and every 6 months we touch base with them to let them know about any new program developments, make sure they're doing okay, make sure they don't have any questions, and talk about living donor, because living donor is a huge opportunity to move forward with transplant sooner. So greater than 3 years of dialysis. That's kind of an average based on blood type. For example, blood type A patients tend to wait less time. They tend to go in a year or two, as opposed to a blood type B patient who waits a lot longer. The transplant coordinator is going to set them up with all the testing that's appropriate for them to move forward with getting ready for transplant. This means they can be called at any time. So we also want to ensure that they're still candidates for transplant. At this point, they're getting their left heart cath or their stress test or their CT to make sure it's safe to move forward. All patients in that readiness phase are presented every single year to ensure they are ready to receive an organ offer. Sometimes an issue is found in their evaluation. For example, they get their left heart cath and they have a blockage. We want to ensure that's taken care of before we move forward. And sometimes that confuses patients saying, but I'm on the wait list. Well, you're on the wait list, but you had a cath, and that cath has shown a blockage, so we want to ensure that's cleared before we move forward. Reachable, they gotta be reachable. We've had a few people miss organ offers because of that. I was in the shower or I mute my phone at night. Well, the only problem is 9 times out of 10, that offer comes at night. So we don't want anybody to miss an offer. Donor allocation, I know that Scott talked a little bit about equity and opportunity. So allocation is based on the most appropriate donor for the most appropriate recipient. So what I'll tell you is the younger donors tend to go to the younger recipients. Well, that opens up, a lot of patients are really hesitant to accept certain types of donors because of the risk. But the risk is lower compared to the long-term mortality on dialysis. All those donors undergo a rigorous assessment. They get HIV testing, their social history is evaluated to determine the risk of transmission of disease. The transplant team will also discuss all those types of donors at the time of the offer so that the recipient can weigh that risk. So these are the different types of transplants. Living donor transplant, best option you can have. As a matter of fact, we have a class now called Navigate the Wait. So anybody who's placed on the kidney transplant wait list attends this class. It's a telehealth class. And what it teaches them is, how do I talk to people about living donor? How do I talk to people about, I need a transplant? So it's another way of opening that up as an option. Standard criteria donor is a donor who suffered brain death but has no other risk factors. But those donors tend to be younger and go to younger recipients. So that's where we open up opportunity. Hepatitis B core donors. Those donors have been exposed to hepatitis B, but they've never developed hepatitis B. So they don't have active disease. Risk of transmission is minimal to zero. Donor after cardiac death donor. It means the donor is not brain dead but cannot sustain life if life support is discontinued. So these donors, there's no difference in outcomes for this donor versus a standard criteria donor. PHS increased risk donors. These are the ones that typically make recipients nervous. They're donors who have a social history, IV drug abuse, prostitution, periods of homelessness, homosexual activity. All of those carry a risk of transmission of disease. But at the time they are evaluated to be a donor, they undergo all of that testing. If they've done it at any point during their evaluation to be a living donor, they may have done it 8 months ago. Well, the risk of transmission of disease is, it would show up on their lab work at the time they're being evaluated to be a living donor. Hepatitis C donor, NAT positive donors. These donors have hepatitis C and they will transmit hepatitis C. The goal is they're treated. Now treatment has become so advanced that they take a medication for 6 to 8 weeks, and we can take care of the hepatitis C. So hepatitis C, positive but not negative donor. That donor's been exposed to hepatitis C at point, but never developed disease. So they don't have active hepatitis C. They're reasonable donors to move forward. KDPI greater than 85%. So this takes into age, ethnicity, diabetes, hypertension, cause of death. And the higher the score is, the higher risk possibly that there could be some delayed graft function. Not that the kidney won't work, but it may take longer for that organ to work. But we go back to that concept, younger donors go to younger recipients. So those recipients who are 50 and 60 years old, it's to their advantage to open up that pool of possibilities for transplant. A2B is a type of donor that A blood types can go to B blood type recipients. They have to qualify through lab work to make sure that they don't react against an incompatible blood type. But the blood type B patients tend to wait forever for organ transplant. So 5-year rate of dialysis. As you can tell from here, the long-term 5-year survival on the wait list for someone who chooses to not accept a KDPI greater than 85 is much lower. Mortality is high. Then you've got your PHS increased risk. So the risk of dying in a car accident is higher than the risk of accepting a PHS increased risk organ. This is what we educate our patients on because we want them to visually be able to see what is my risk of doing this because we want them to be transplanted. Bless you, my friend. So Hep C positive, NAT negative. See that little half person there? The risk of dying in a car accident is higher for transmission of Hep C. Key points to remember, living donor. Living donor is the best option they have. This Navigate the Weight class that we're offering now has been really an excellent opportunity for recipients. Patients have to answer their phone because we've had several people miss the call and they call back in the morning and say, oh, can I come in now? We typically only have about an hour to follow up with that organ offer. They'll be updated twice a year on our transplant outcomes because we want them to be confident when they come in for transplant. We will notify you of any changes in our program. You'll be notified and so will the patient. So the kidney transplant, you've probably seen this picture before or something similar. The kidney transplant is typically placed on the right side in the front. Unless there's an anatomical issue and they may place it at the left side, old kidneys are not removed. So it's in the surgery itself, and you can click it forward. The surgery itself takes about 2 to 3 hours. They go to a floor, a regular floor after they receive their transplant where they're monitored very closely. Their length of stay is about 3 days. They meet with everybody on our transplant team, and our goal is that, the longer you're in the hospital, the higher the risk there are going to be issues. Our goal is to get folks up and get folks moving along so the recovery is quicker. If you live farther away, for example, the Tyler population, the Lubbock population, the out-of-state, we ask that they're ready to stay in our area for 1 to 2 weeks to make sure if there's a complication, we can intervene quickly. That they're not trying to navigate a foreign hospital with their history. So there are risks, unfortunately, to transplant. Diabetes and high blood pressure are the highest risk post-transplant. If they have any family history of diabetes, more than likely they may develop some blood sugar issues. Bone disease is another one. Skin cancer is the highest risk post-transplant. We push sunscreen as though we make it ourselves. And we also push seeing a dermatologist annually to make sure there aren't any cancers developing. Infection, they're immunosuppressed. So they have a higher risk for infection, and we have a lower threshold for bringing them in to assess for an active infection. Loss of the kidney is rare, but it is a risk. But one of the big ones, I think, that become a concern for a dialysis unit is, wait a minute, we sent them for transplant and they're coming back for dialysis. What happened? Well, sometimes that kidney takes a minute to wake up. And so we call it the sleepy kidney. It needs to be kicked into gear, but the patient needs help with volume management and they need help with electrolyte management until that kidney fully kicks in. Sometimes it takes a few days, sometimes it may take 2 weeks, but the kidney will kick in and we move forward and they get off dialysis. We started this several years ago, Transplant Freedom Day. What it is it's kind of a multidisciplinary approach. We discovered that, with a 3-day admission, we need to ensure that patients feel confident going home because 3 days really isn't very long when you're changing your entire regime. So what we do the last day before they're discharged is the patient gets to take care of their medications, their blood sugar checks, their urine measurement, because we want them to be confident in saying, yeah, when I go home, I can do this. I can read my med list. I can take care of these issues, and I know what to call for if something becomes urgent. What we discovered is when they're empowered to care for themselves, they're less likely to be panicked in the after hours and calling because they don't know the answer and they're worried they're going to compromise their kidney. And I'm open for questions.
Let's give Ms. Laura a hand. Thank you, Laura. So we have questions coming in. I think you have a total of 11 questions so far, so prepare yourself. And thank you all for submitting those questions. The first question is it required now to have Medicare now due to the expanded transplant drug coverage?
It is not required to have Medicare now. Any private insurance will do. We do encourage, to be honest with you, we do encourage Texas Kidney Health. So if your patients are not signed up, please sign them up because post-transplant, it totally helps with their meds. Medicare also helps with meds, and they're given that option. If they don't have Medicare at the time of transplant, they're given the option during their transplant admissions to sign up.
Okay. Next question, is there any information available to give to my patients explaining what to expect when they're getting ready to begin the pre-transplant process?
Oh, we have all sorts of educational documents. So it sounds like we need to get with Ivani and share some of our tip sheets with her about what we educate patients on. We have one they can put on the refrigerator that says, what can I expect from this? And then the other one that is basically outlines every possible test they could have that educates them on what to expect.
Okay. Next question, how long does it take for the one-day evaluation?
1 day. When the scheduler reaches out to that patient, they literally are scheduled for 1 day. They come in, and typically what will happen is they may do a telehealth education with the coordinator a few days earlier, but then they physically come in 1 day and get their labs and see the nephrologist and potentially see the social worker.
Okay. Next question is, what is your opinion on the efficacy of cardiac rehab improving patients' eligibility for transplant?
I think you mean cardiac rehab if they've had a procedure. If they've had an intervention and they've been asked to go to cardiac rehab, we are 100% supporters on that because overall it's going to strengthen them prior to moving forward with transplant.
Okay. Next question, does substance abuse include alcohol?
Well, it depends. I mean, how much alcohol are you drinking? Is it impairing your ability to function? One of the things, so I have a couple, so they say I have a couple drinks every now and then, a couple times a week. If it's not intervening and they haven't been arrested for DWIs or, had job compromises, it's something to look at. It's more case to case. It basically, we have to weigh it out of how successful, if it's going to interfere with their success post-transplant.
Next question, expound more on substance abuse, given medical or even regular marijuana and things like that.
I knew this was coming. So illegal drugs, we can't move forward because, variety of different reasons from putting someone at high risk for issues at the time of transplant or post-transplant, not to mention the legal potential. So I'm going to say this, and Scott's going to be upset, but marijuana is one of these things that we don't like it. But if you test positive, you're not going to be turned down for transplant. As long as it does not interfere with your ability to follow a transplant regimen, we do not count it against them in terms of their candidacy.
Okay. Next question, what's the longest that a patient has waited for a transplant after being listed?
Oh, that's a variety of different factors. So we've had people who are second time around transplants who've waited. Their immune system is such that it's very difficult to find an organ. I have somebody that's been on the wait list now for 9 years. Unfortunately, they are second transplant, and there's something about their immune system that reacts against most donors.
Okay. How does diabetes play a role in pre-transplant evaluation?
So diabetes, as you know, it causes a lot of damage. It's kind of a silent damage causer. So when somebody has been diagnosed with diabetes and they have type 2, for example, and they've had it for at least 10 years, we typically move forward and get what we call, a left heart cath. We want to see what their vessels look like to make sure that there aren't any blockages that need to be cleared prior to moving forward. And every year after that, we'll alternate between a stress test and a left heart cath because it's such a silent disease.
Okay. Can HIV patients donate a kidney to other HIV patients?
Unfortunately, not at this time. However, they have what they call the HOPE Act. Allows HIV deceased donors to donate to HIV recipients. They tend to not wait as long, and the outcomes are very good. Unfortunately, with living donor HIV, right now we are not moving forward with that. I don't know of a center that actually is.
Okay. Next question. Can HBV, core positive kidney, transmit HBV like HCV does?
Woo, that's a lot of HBs and
C's and B's.
So it depends. So hepatitis C, being a hepatitis C positive donor, but your NAT is negative, for example, means you're not replicating virus. That's very similar to a hepatitis B core positive donor. They're not replicating virus. They've been exposed and established. We call that the natural immunity. They've been exposed, but they've never developed disease. The risk of transmission is less than 1%.
Okay. Next question. If someone receives a kidney from someone who is HIV positive, do you test positive for HIV, and what are the chances you actually contract the virus?
So if a patient if a donor tests positive for HIV, those donors would go to potentially HIV recipients because they already have HIV. If you're transplanting a donor who has HIV, the person that's getting the kidney is going to be HIV positive. Now, I think that kind of weighs into the concern about what if the donor popped up positive down the road, deceased donor, they rule out those risks based on their social history and their labs to determine, okay, what's the long-term risk they could be positive? Post-transplant, HIV medications have come an extremely long way. We test patients 6 weeks post-transplant, which gives them enough time if they were exposed, regardless of what the deceased donor's labs looked like, if they were exposed to pop up positive for any transmittable disease. At that point, we treat it so that we can move on.
Okay. Why are patients higher risk for developing diabetes post-transplant? And is this both type 1 and 2?
Type 2. It's mainly type 2, and it's steroids. We give high-dose steroids at the time of transplant, extremely high dose, and then they're on a long-term maintenance steroid as well, and it just pushes your pancreas to be able to control the blood sugar.
Last question. Guys, you've been doing really good submitting these
I
questions.
know, I'm loving it.
Last question. Can you please explain the wait list on dialysis? The longer the patient stays on dialysis, they will move to the top of the transplant wait list? Question mark?
Oh, so what you mean is, okay, if a patient was placed on the average wait time is 4 to 6 years. If the patient is placed on the wait list today, but they started dialysis in 2019, they're going to get 5 years of wait time. Now, moving to the top of the list is a little squishy because it's blood type dependent, it's match dependent, it's immuno dependent. So I know patients always want to know, where am I on this list? We can't tell you exactly because every deceased donor is going to be a little bit different. And compatibility is going to be, just because they're blood type compatible doesn't necessarily mean they're going to be that perfect match. Immune system plays a big role in that.
Okay, we did have one more question come in. Can the outreach clinics refer to your weight wellness and the patient complete a telehealth visit?
I think they do telehealth, don't they? The weight wellness? Yeah, they can refer. And we could probably give Yvonne that contact information so that she can assist in that referral process so that they can reach out.
All right, so Laura, that's it for you. Y'all, let's give Laura a hand. Thank you, thank you. Thank you, thank you. So everyone, if you didn't think that was a treat, we have another treat for you, okay? And it's not, I know Halloween's over, so it's no tricks here, just treats. You only get treats here. So our next speaker, great transplant advocate, and she has very valuable information to share with you. Please help me welcome Dr. Sui Ling Levy. She's our medical director of living donor kidney transplant.
Good morning, everyone. We have a good turnout here in a cold day today. Hope everyone had a good Halloween. So as Ivani was saying, I'm Dr. Levy. I'm one of the transplant kidney doctor, and one of the other interests I have is living donors. So I'm the living donor medical director here as well. So today I'm going to give a little bit of an introduction about living donations, and then my favorite section is actually what I like to call the busting the myths about living kidney donation. Really talking about the things that patient talks a lot about in clinic, some of the things that they might have heard about, that there are some truths and sort of somewhere in between. And then what we do here to evaluate potential living donors. And I'm going to touch upon just very shortly about how to have the big talk, because I know Taylor is also giving the talk later on. So I want to give her the stage for that. Now, the big question always is, patient will say, well, I'm doing okay on dialysis. Why do I want a transplant, right? But I think this is a good capture of why transplant is so important. So if you look on here, there are different color bars on 5-year and 10-year survival for patients. The dark blue are basically patients that are on dialysis. The light blue is the deceased donors, and then the orange is the living donors. At 5 and 10-year mark, I think it's quite clear where the benefit is. You see that the dialysis patient are only 20% still living at 10 years on dialysis. And you look across the board, the living donors and deceased donors do way better. Now, of course, the orange bars are the living donors, and they are doing way better than the rest of them, okay? This is a picture that's shown to many of patients, and also many of us in this room have seen something similar to that. The reality is the kidney transplant waitlist is growing, with many people waiting for this kidney transplant. Laura's highlighted how long the wait time potentially could be. Here in Texas, it could be 4, 6 years, or sometimes maybe 2 years, but on average, it's still that it's a long several years of wait time. I want to highlight sort of what actually happens to these people when they get waitlisted, right? Patient gets really excited. They come back after they get seen by us and say, I got the phone call. I'm on the wait list. This is awesome. And then those of you who are rounding on them on dialysis, they will say, well, no one ever calls me. I've been waiting. They call me and say, hey, we still know about you, but I'm not getting that offer at all. But this is really to highlight that. So you see here on the blue area is the patients that are waitlisted. The greens are the people that are removal from waitlists. And then you have the gray area, which is patient death. And then below are the transplants, which is the red from deceased donor and the blue from living donors. You can see from the beginning, there's a lot of people on the waitlist. At about 3-year mark, there's more patients that are transplanted. There's still a good amount that are still waiting on the waitlist. And then by about 5 years, right, there's still a decent amount that's still waiting. But let's not ignore the part that there's this green portion that's getting bigger and bigger, right? The longer they stay on the wait list while on dialysis, other things could happen, right? They're on dialysis with a catheter, they could get an infection, and they could have a heart attack. Different things could happen to them. So it is very important to get them transplanted in a timely manner. Well, when we talk about transplant, our 2 options really is a deceased donor, which is off the wait list, or a living donor. Deceased donors are tough. I think Laura's highlighted a bunch of it about how we really don't know when that could happen. I tell patients it's asking me to predict when a patient will pass away in the right way to be a good match to you to get that transplant, right? There's a lot of different factors into it. So living donor is the other options where you could get your transplant in a timely manner. Perfect, thanks, Yvonne. Okay, so what are the benefits of living donor transplant? It's shorter wait time because you can do it as long as your living donor is approved. You can get transplanted a month after you get listed, 3 months after you get listed, a year after you get listed. It can occur before a recipient ever goes on dialysis. This is really the big key. I always tell people that these are called preemptive transplant. In reality, when someone has kidney failure, the first line of treatment really isn't dialysis. It should be a transplant. They should never have to go on dialysis first. Unfortunately, the initial treatment of 2.5% of patients in the United States that develop ESRD is actually transplant. This is not a very good number at all. And nationally, only 20% of transplant are actually what we call preemptive. So they're a chronic kidney disease patient that ends up getting a transplant. Here at UT Southwestern, I do have to highlight that I'm very proud of our numbers here. In 2022, 25% of our living donor cases are preemptive. And so far in 2023, it's 30% of them. And a part of it has to do with the fact that when they come through the evaluation and they identify that they have potential living donor, we say, great, here's what we're going to do. Have them apply, and we'll work through them as quickly as we can, however we can help you. And we'll get the recipient ready as quickly as we can, okay? So what are the benefits that we've highlighted already, which is the improvement of long-term outcomes for kidney transplant recipients compared to deceased donor, and also the ability to plan for that surgery. So some of our patients, right, they have support, the children that may have to come from somewhere else. It's very tough when the phone call just come and they have to show up. Versus here, if you have a living donor, you can say, you know, summer break is great, spring break is great, let's plan on those. The teachers are out there, this is a perfect way for them to schedule their surgery in there. All right, shifting gears a little bit, what I like to call busting the myths. So these are a few items that I like to highlight on the 6 common things I hear about from both recipients and living donors, because nowadays with social media, there's lots of chatter out there. So you hear certain things and you don't hear certain things, or patients will hear about some things at the dialysis unit from other patients. So I like to call these busting the myths so that, you know, we can educate our patient differently. So the first one I always hear about, I can only get a kidney from my family. Doc, I'm single. I can't have any kidneys. What am I going to do? Wait on the wait list? Truth of the matter is anyone can be considered for kidney donation. It doesn't need to be someone from your family. It could be your neighbor, it could be your friend, it could be someone from a church community. When we think of living donation, really I like to group them into 4 groups. Living related, which is really someone that's biologically related to you. So we commonly think about parents and children, siblings. Living unrelated will be someone like a friend, spouses, are the common ones. The third one is non-directed or altruistic. Someone, you hear about this in the news sometimes, someone just decided that they want to do something good for the community. So they will come here to UT maybe because they're in Dallas and say, I heard about your program here. I really want to help somebody. I don't care who gets my kidney. I just want to give the gift of life to somebody. So these are your non-directed or altruistic donor. And last but not least is pair exchange. I really want to touch on this one, largely because that's the other thing that comes up. Next question when I talk about this for a patient is, Doc, what's my blood type? Because I have to make sure, right? Because I don't know what my blood type is. How would I know who can be my donor? And I always tell them it doesn't really matter. Why? Because if your goal is to really to help someone with a transplant, it doesn't really matter, right? If I want to give Ivani a kidney and we're not a good match, but at the end of the day, I really just want Ivani to get a kidney. Well, if Helen wants to donate to Scott and they're not a good match, but we're a good match, we could just swap our kidney. So here's an example of what I'm describing. Not a match, whether it's blood type, antibody, sizes, similar on another pair, you have the same issue. But the goal really is, as long as I want Ivani to get a kidney, doesn't matter who my kidney goes to, because she will get a kidney in return in the swap. We swap these kidneys. Or you hear about it as kidney chain or pair exchange out there. This is an example of just 2 pairs. You could get as many pairs as possible to exchange them. So another picture to highlight pair exchange. Oftentimes we think of it as just a blood type issue, but sometimes it could be not a perfect antibody match. Sometimes it could be a big size difference. Like if I were to donate to, like say, Shaquille O'Neal, I'm a little small for him. We need someone a little bit taller than myself to donate to him. We can swap a kidney for those reasons. So there are a couple of programs in the country. So you have OPTN, Alliance for Pair Exchange, and National Kidney Registry. These are opportunity for exchanges, okay? Second myth, well, I don't want my kids or my friend to not have a good life and end up like me. The truth is, living kidney donors live a healthy, normal life with one functioning kidney. You have to remember that donors tend to be the healthier people out there. So if they're already healthy coming in and we're screening them and we're learning about their health, we know that their risk is small. So we also continue to empower them to continue to exercise, continue healthy living. We make sure that those who are not completely plugged in with the PCP yet, we do a referral here for them so that someone can take good care of them for the rest of their life. And the data does support that. So this is a publication from University of Minnesota where they looked at close to 4,000 of their former donors, and they followed them over basically 40 years. The black solid lines are donors, the dotted lines are the controls, which are the healthy non-donors in the population. These two lines are almost overlapping. So what it shows you is that these people are doing great. I just gave a talk to the trainees recently, and I highlighted to them the first living donor case ever in the United States was in the 1950s. It was a twin to a twin. And the donor donated at the age of 23, and he passed away at the age of 79, and only needed dialysis the last year of his life because of his heart problems. Okay? So people can live a really long time. Remember in the 1950s, we were doing a lot less testing then too. So now, third thing, well, only young people can donate kidney. I still vividly remember a patient telling me that he's in his 60s, he's not that old. And he's like, well, I have no kids, what am I gonna do? And the sister next to him looked really offended. And I was like, that's a really good point to highlight. We think of only like the 20s and 30s can donate, but in reality, really anyone can donate. But just because you're older, whatever that age may be, there is really no clear cut to say if you're 65-year-olds, you can't be a donor, because I've seen the 65-year-old marathon runners out there. So they're really not necessarily an overt age cutoff for kidney donation. Obviously, if you're older, let's say you're over the age of 70, we do a case-by-case scenario. And where do we know this literature from, right? This is a study that was done looking at older donors and comparing them to individuals that were in the retirement study to look for basically death and cardiovascular events. So here, I dotted it in red. The dotted lines are the donors, and the black filled-in lines are actually the control. They look similar as well. Therefore, we say that carefully selected older donors are not at higher risk for death. All of our donors who are over the age of 50 get to have a workout the day they come and see us with a stress test. So this way, we can actually highlight that what their actual risk factors might be. This is one that almost everybody always brings up with concern. Living kidney donors are more likely to get kidney disease after donating. I can't have my kids in the same position as I am. So this is both true and also false. The reason why I say that is because in the literature, the relative risk of kidney disease among the donors is slightly higher than the healthy non-donors, which is not completely surprising, right? Because I'm taking a kidney out of somebody and leaving them with only one kidney. That kidney does grow over time, but is never going to grow back to that 100% where their starting point is. However, when they actually look at the data very closely, the absolute expected incidence is still very low, it's less than 1%. Okay? So compared to the general population, the risk of developing kidney disease is still much lower. Living donors tend to be much healthier than the general population as well. Because oftentimes when they come through the screening, we've seen them, we gave them tools to be successful long-term, and they check in with their primary care physician, and they do a lot of things to make sure that they basically continue healthy living. Living kidney donors will be at the hospital for a really long time. I think it's going to stay here. They have a job, they have a life. They generally stay in the hospital for 1 or 2 days at most. And by the way, the risk of death for donor nephrectomy is very low. Well, oftentimes they look at me and it's like, well, what does that actually mean? What does that mean in comparison to what, right? What does low actually mean? Here's a study from 2010. They basically looked at former donors and they compare on the red little bar down there is the donor nephrectomy, which is laparoscopic. The yellow little line there is something that everybody knows about, gallbladder removal, right? How many people knows actually had a gallbladder removed? They come, they get it taken out, no big deal, I went home. And then the last one, green one on there, is actually if I had my kidney taken out for like kidney cancer or other kidney complications. Here you see how taking a kidney out of a living donor is a much lower risk than actually someone that have their gallbladder removed. That's a routine surgery for many people, right? So it's a very safe procedure. All right, many of my donors are women, and it's, in fact, you look at the national literature, donors are primarily more women than men. So this is actually a big question, both for the recipient and the donors as well. Because many parents will say, but my daughter is so young. My daughter-in-law, so they just got married. What if they want to have kids? Is it going to affect her ability to have children? Living donors can have kids after donating. It's not a reason to not have children. The maternal outcomes for pregnant kidney donors are comparable to those who are non-donors, but I do want to highlight that there is an increased risk for high blood pressure during pregnancy and preeclampsia, or some people used to call them toxemia. But the event rates are actually quite low on these. That means that just because they've been a donor doesn't mean that they have to see some sort of high-risk OB. They just need to make sure that the OB knows that they've had a kidney, they've donated a kidney before. And for the babies, there's no difference in the fetal outcome. So what does that mean? They are still not premature birth. The babies come out and they're the normal size like everyone else's baby. So shifting gears a little bit, I'm going to talk about the living donor evaluation itself. These are the absolute no's. So I put on here age less than 18, mentally incapable of making informed consent. So anyone that can't do informed consent. Uncontrolled hypertension. So we're talking about end organ damage like eye issues, or if they have heart issues or kidney issues, or greater than or equal to 2 blood pressure medications. Diabetics are non-donors because they need those kidneys for themselves. Anyone that has active cancer, untreated cancer, untreated mental health, evidence of any donor coercion, kidney stones. If you've had more than 1 kidney stones and the type of kidney stone you have are those that come back all the time, then the answer is no. And then those whose BMI is greater than or equal to 35. Let's say if they show up to clinic that day and their BMI is 35.01, we don't turn them away. We still see them. And Laura's highlighted the Weight Wellness Clinic. Here we actually help them basically meet with the dietitian. And then we also help them get into the Weight Wellness Clinic as well. Some of these things are very obvious, the heart disease, the ones that have polycystic kidney disease. Now, obviously, if I'm a recipient with polycystic kidney disease and I have family member who wants to donate, if I'm only 25 years old, the cyst might not have formed in my kidneys yet. So if they answer the question and say that I'm donating to someone that has polycystic kidney disease in my family, we do inform them that we will be doing a genetic testing to make sure that they do not carry the gene for PKD. Because ultimately, we want to make sure that we're doing the best thing for the donors. Lung disease, and of course, the low kidney function and protein in the urine, these are all evidence of marginal kidney function. We want them for the donors themselves. Refusal of blood transfusion is largely because bleeding is very uncommon, but anytime someone goes through surgery, we have to be sure that something unexpected happen, if they need blood transfusion, they should be agreeable to that because we do not want to put them in that position. And then the history of sickle cell trait or disease. This is largely because these diseases are associated with slightly higher increased risk of kidney disease. So we want to make sure the donor has the kidneys for themselves as well. Now, smoking history. It is not an absolute no, but they have to be willing to quit 6 weeks before donation. This is largely driven by safety with the surgery and wound healing as well. Obviously, quitting smoking is really, really good for them. So I always tell them that by the time you quit for 6 weeks, you should keep on with it. A good job of that. I offer all smokers in our clinic a referral to our tobacco cessation program. We have a fantastic tobacco cessation program on campus who are very successful. And I offer all of our donors that, because if they're already going to do it, they're motivated, this is the time to keep on with the good work. Anyone that chewing tobacco, they have to get a dental evaluation because we want to make sure that there's no evidence of oral cancer in there as well. Because remember, all the things we do for the donors is all about the donors. It's for their safety. It's for them to have a great quality of life afterwards. And then anyone that have history of mental health, depends on the assessment. If they're well controlled, we're good with it. But if there's any concern that we may have, because ultimately we have to remember that some of these people have never had a surgery before. The feelings and the emotions that go into the kidney coming out and going to somebody, and off chance that the recipient may have some hiccups in their recovery, there's a lot of emotions that tie into all of these things. So we just want to make sure that they have all the tools to be successful. Now, shifting gears, how do I apply to be a kidney donor? We do have paper application, but majority of our applications are now coming through an online applications. There's a link on it. I know Ronnie can provide that in the packet too. It's a application that anywhere all over the world and in our country, you can just click a button and apply for it. So I always encourage everybody, all our recipients, when they're going to share the word out there, to take a picture. So this way, if someone suddenly asks about it, they can just screenshot it and send it to anyone that's interested, and it's a click of a button. You can apply anywhere. So the first screen, just to prompt to show you what they say on as you put in all your information, it even allows you to say what's a good time for our team to contact you. Because there are people who work that may not have their phone on them. And then what that brief application will go through, because it will take you less than 5 minutes to apply, at most 5 minutes, even if there's a lot of history, to put in all these medical information, surgical information, family history, and on the social history part, it does prompt for that question, are you willing to quit smoking for 6 weeks? Medications, and ask questions about PCP or not. Many of this is to help us be ready for the donor to come in to see what are the services that we may have to provide for the donors. Once they screen through that and everything looks good, and the recipient's waitlisted with us, they'll get a phone call from one of our living donor coordinators and say, hey, we got your application, nice meeting you. Now, we are not making any donors come and do all of the workup the moment they pass a brief screening, because we do understand that this is a big ask. So what we do then is we screen them, we call them and say, if you're still interested, let me know where you live. We look for the closest labs as close to where you live at home. At your time of convenience, we need some blood work and some urine studies. So this way they can go on a weekend or wherever they need to be, and they do all these testing. And once they pass through those screening, if the lab work all look great, that's when we start out what we call the phase 2, where they have to physically come to UT Southwestern. Now, during this period of time as well is if you've had a mammogram, a colonoscopy, anything additional that's been done, this is the timing where our coordinator will ask for that. Because lastly, this will help us prepare for the visit and know what else might be needed at the time. Phase 2 is here. Typically, we can complete this in 1 day. And I use the word typically because if you're over, let's say 50 years old, you may need to do a stress test. So that might be the next day sometimes. Otherwise, if you're, let's say, a 40-year-old, it's a 1 day deal. So you come here, you get education, you get seen by the kidney doctor and the surgeon, and you get an EKG, an X-ray that day, and you get a CAT scan to look at your kidney, how many blood vessels they have, the sizes. And for the donors who are all greater than or equal to 50 years old, we do a stress test. And this is assuming there's nothing else that day. Then you're done with your evaluation, you get seen by our social worker, and then the ILDA will check in on you again. I want to take a little bit of an extra thing to put in here because I know we've gone through some of the slides before to talk about blood pressure evaluation. This is the most common thing we run into where people's blood pressure is a little bit higher in clinic because it is very anxiety-driven process, interestingly enough. The recipients will come in and their blood pressures are like perfect. My donors come in, these young ones, their blood pressure sometimes is through the roof. And they're sitting in there and on their hands and looking at me like they're going to fail a test. So I tell all of my donors, you can never fail this evaluation. Because by wanting to be a donor, you're already like a hero. The goal of this visit, if for whatever reason someone gets turned out, is because we want to make sure that they can keep those kidneys for themselves, okay? So they get real anxious, so we check the blood pressure twice for my visit, and then again with the surgical visit. They have to be 5 minutes apart, and they're resting in a room, and they're more comfortable. So this way, not everybody becomes hypertensive by diagnosis. So if you're less than 130 over 80 in office, and you're non-obese, you're good to go. But there are some people whose blood pressures are high, and they may have what we call end organ damage. So for barring that we didn't know that they have basically eye issue, have a stroke, and then they are using multiple blood pressure medication, then they do need those kidney for themselves. And we tell them that you're not a great candidate because I think you should continue with what you're doing now, make sure you're plugged in with good care for your high blood pressure. But what about the gray zone? The people who are older, who are on 1 or 2 blood pressure pills maybe, obstructive sleep apnea, and their blood pressure is above the new definition, which is 130 over 80. And, or even like the young people where they're super anxious, and the more we check their blood pressure, the more anxious they get, because now they're like, oh my gosh, I'm really failing this. And I'm guilty of that too. As I work in a clinic and a hospital, my blood pressure is really high. I have white coat hypertension, and I wear a white coat all the time. So these are the people that go to the clinic, their blood pressure is super high. We don't just say, yeah, too bad for you, go away. We want to give them the benefit of the doubt. And it's the right thing to know too, because if they really have high blood pressure, right, we should plug them in with somebody. So what we do is a 24-hour blood pressure. This is a gold standard to look at it. It's a machine that they bring home with them. They wear it. It squeezes their arm throughout the day when they're sleeping. They get to write things down like, I had a cup of coffee. I had something else that I was doing that day. My boss yelled at me and I got really upset. So they have a diary that they write down all the times on it. And that 24-hour blood pressure will give us a guidance in terms of like, what is the average blood pressure, A, and B, do they have what we call nocturnal dipping, which means that when they sleep at night, their blood pressure actually goes down really low. Those are actually signs of someone that even if you do have high blood pressure, your likelihood of developing resistant high blood pressure or bad outcome from your high blood pressure is less severe. So let's say we do that, and then we look at their ultrasound and make sure that of the heart, the echocardiogram, and there's no what we call LVH, which is the wall thickening from long-standing high blood pressure. Then, if it's elevated or abnormal, then they end up becoming non-donor because they need it for themselves. Anyone that carries a diagnosis of high blood pressure, let's say if they're 55 years old, can still donate. But we have to look in their eyes to make sure there's no end organ damage, look at their heart to make sure that they're doing well as well. Because remember, this is all about the donor, right? Now, let's say this workup is, I pressed the wrong button. If it's actually normal, then they can still proceed with donation, but we definitely give them all the tools. Make sure you maintain the healthy lifestyle, the walking 3 to 4 times a week, making sure that the PCP that you're doing, that you don't lose track of them. Now, I see some people looking like, high blood pressure, we are saying that can cause kidney disease. We're going to let donors donate with it. So what are the data behind doing that, right? So this is a study that basically looked at 15 years, and we allow older donors, so individuals that are greater than or equal to 50 years old, who has well-controlled high blood pressure to donate, assuming that there's no end organ damage, so like kidney issues, protein in the urine, or if they basically have eye damages or heart damages from it. So when they look at these people, I want to highlight that at 15-year risk of end-stage kidney disease, for the donors with high blood pressure, 0.8%. For the donors without high blood pressure, 0.2%. It's not that much higher. And they actually saw that there's no significant association between the donor high blood pressure and 15-year mortality. So they still live a good quality of life, but there is a risk that is slightly higher than those who are not being on blood pressure pills, okay? Similarly, this question actually asked because, I feel that every time I blink, high blood pressure is essentially a different name for it or different guideline or criteria. This actually asks a question, what if we change it from 140/90 to 130/80, which is sort of the newer definition? And in reality, I want to highlight that on the, let's see, my point. These portions are the ones that have high blood pressure. This portion is what they call normotensive. You can see that the numbers are actually quite similar, okay? So in reality, carefully selected one looks okay, but they did notice that there's a slightly higher risk of cardiovascular event for those that we use the older criteria, which is why now we use the new blood pressure definition. The age-appropriate cancer screening, we ask them in advance, we can plug them in for a pap smear. So if they already done it with the PCP, we can bring them here, okay? The independent living donor advocate, I want to highlight really quickly that they are really the individuals that make sure that we are doing the right thing, that the donor got all the information they need and no one is pushing the donor to donate. So this is just to highlight what are the things that, the ILDA go over with them. So the big question really is, well, I've completed my eval now what happens? For the 40-year-old, remember they got all their labs done already. They just got a CAT scan that day, barring any surprises. We meet once a week for our committee. They should be able to go to committee within 1 to 3 weeks at most. And then once they're approved, they'll get contacted if the recipient is also ready for a surgery day, okay? Now, our surgery day is now scheduled. What should I expect on the day of surgery? I always tell all the pairs that the week before you do have to come here, you get labs drawn for that final cross match. You get seen in clinic by the surgeons, ask any last minute question that you still have. Paperwork for FMLA and things like that can get addressed during that timing. And then if they're on dialysis already, we coordinate sort of like if they need to change the schedule a little bit to accommodate for the living donor surgery. And then on the surgery day, they'll come to that hospital right here. I got confused for a minute. And they check in and pre-admitting. The living donor surgery are laparoscopic. And then once they get done, they go to the floor. They go to the PACU first. They recover, and then they go to the floor. Once they get onto the floor, they hang out there being monitored by our entire team, which has nurse practitioners, surgeons and nephrologists on it. They'll have the Foley catheter that can basically get removed about the next day. They get blood testing done. They get started on clears. And once they tolerate the diet they can eat, they get pain management. They start walking pretty quickly. And almost all of them go home the next day, or at most sometimes like, a day and a half later. From a post-donation follow-up care standpoint, they get a 1-week post-surgery visit with the surgeon, and then they can return to work by about 4 to 6 weeks. The donors who work desk jobs sometimes are getting bored, and we do let them go back to work a little bit earlier, but I do tell them no heavy lifting within the first 6 weeks because we don't want them to develop a hernia. This is very important. This is why I ask them what they do for a living all the time, because your daycare or the young parents, those babies are always exceeding that 15-pound cutoff that we have for heavy lifting. And then clinic really with us is with labs at 6 months, 1 year, and 2 years post-donation. We tell them that, however, anytime in between, if they have questions, they can reach out to us directly. And then we recommend annual visit with the primary care physician. So I want to finish off real quickly because I know Taylor is going to spend way more time on this, but it's hard to talk about living donors. We're talking about the big ask and the big give. So I always tell people the more conversations you do, the more potential donors you would have. And more potential donors is actually a good thing because life happens for many people. People are always hesitant to talk about these things, so it's very normal. And I encourage them to raise awareness. I tell them that I just met you 10 minutes ago. I know so much more about you than you've told even like your neighbor that lives next door. If you're willing to share that with me, think about how you want to share that story to the world around you. We can use social media and we can use conversation, letters or emails. And then this is where I segue into Taylor. Living Donor Champion is really someone who's going to go out there and tell people about how living donation is important, what is the process like, how can you help somebody. This could be anybody really, like your family members, your children. Donors who are not candidate, like they get turned down because of their health reason, they can become a living donor champion for the patient. And here at UT Southwestern, we have the very good privilege of having Taylor, who's a living donor champion, and she will help our recipient create a story, okay? I'm gonna stop here and thank everybody for your attention.
Thank you, Dr. Levy. And we'll take a few questions.
Okay.
Oh, I'm sorry. We'll take a few questions at this time. First question is, what if the living donor lives in another country and is willing to come to the U.S. to do the donation process?
That is a great question. So obviously that phase 1 and phase 2 gets a little tricky when they're from a different country. We have them just fly here and we schedule everything for them. Now that say, obviously this will no longer be a 1-day evaluation in some sense because they have to get their blood work drop off. It may end up being a 2 days version of it. And we do tell them that if they can stay for a few days, it will be better. Most of my donors are flying in from a different country. We've had them from South America. We've had them from like Asia coming in. They tend to stay here for a little bit of time because it's not a short flight back and forth. So they also want to know the committee decision before they go back. So we fly them in here. We arrange with them ahead of time to make sure that we know everything that will be needed of them. And then we schedule everything for them. So they basically get a tour of our clinic and do everything during that visit.
Next question is, in a paired exchange, what if one of the living donors back out at the last minute? Do they sign an agreement to move forward?
Oh, this is such a tough situation because, even on a direct donation, if I want to donate to Ivani and the morning of surgery, I'm like, you know what? I don't think I can do it. I really just cannot do it. And they decided they didn't want to proceed. It's very hard for the recipients as well. And it's a tough decision for the donors. So even if they sign an agreement, ultimately they get a chance to change their mind at the very last minute. And those are very tough situations. Thankfully, we have not had to experience that here, but the pair happens on the same day for that reason. We want to make sure that no one backs out last minute. And if it's going to happen all at the same time, everyone's already there. So we know before we start anybody on the surgery.
Okay, next question, I'm going to kind of paraphrase to combine a couple of questions. If a person donates to another individual and they in turn need a kidney down the road, will they be escalated up the wait list?
That is a great question, right? We want to ask ourselves about, is there a backup plan for us? And yes, they are. they do get some priority points to be higher on the wait list because we have to acknowledge that they give the gift of life. Be it that because they got in an accident and it damaged the only kidney they have, they should not sit on the dialysis wait and wait for a kidney transplant. So they do get some priority points to be higher on the wait list. So their wait time is shorter on the wait list.
And last question, is there a cutoff for eGFR to donate? For example, for a 60-plus-year-old person, no hypertension with an eGFR of, and it says 6, but I don't think that's
60,
right.
I think.
Yeah.
So that's a great question. This is a hot topic right now in the national committee standpoint. So the absolute cutoff right now really is around 80 for most centers. Now we can say that if you're 72 years old, can we do a case by case and say that really if a 72 years old donating their spouse who's 71 years old and their GFR is 71 and they're willing to take the risk of being defined, having a CKD afterwards, should we consider those? So right now for us, 80 is still really where we're looking at, but there's still some case by case discussion. And I'm hoping that in the next couple of years, maybe next year, I'm hoping we have some new updates because there is a work group on the national committee right now that's looking at exactly that the GFR should not be a black and white. Rather, it should be an age-based and actually also size and gender-based as well. Because men and women are not the same in the way we're measuring those creatinine clearances. So there is a work group that's working on that right now. I'm hoping that I have some new updates soon in the next year or the year after the latest.
Thank you. Thank you, Dr. Levy. Okay, so you will be receiving a copy of the slides after the event is over, so you don't have to try to snap every picture or jot down so many notes. I saw a couple of you frantically writing. Just wanted to give you some relief of that. We didn't want you developing hypertension in here, since we've already discussed it. Our next speaker, I'm excited. We have a treat for you. Remember, no tricks. We have a treat for you. Her name is Taylor McClaskey, and she is our Living Donor Champion Coordinator. We are so excited to have her with us and excited about what she's able to do with our patients once they get waitlisted with us here at UT Southwestern. So let's welcome Taylor.
Thank you. Good afternoon, morning. It's that kind of weird time. So let's just get a little bit started here. My name is Taylor. I'm the Living Donor Champion Coordinator here at UT Southwestern. Please don't attempt to say that 3 times fast. It's not that easy. So to get started, who here has heard about the Living Donor Champion role? Anybody? Okay. Not UT people? Okay, hopefully some of you at home are shaking your heads yes. Don't worry, we will definitely talk about what a living donor champion is, how this process works, really starting that conversation, and then we'll end up with a personal journey. So how many champions do we have around? Does anybody know? There's a lot. We know in the dialysis unit that a patient has transplant champions, so this will be an interdisciplinary team, which you will hear Ms. Giovanni talk about here in just a little while. And then here at UT Southwestern, we are the champions. Thank you, Scott. And they have a living donor champion coordinator and myself to help these patients navigate their search to finding potential living donors. So I typically ask a patient, who can help you take up the charge? And this is where a living donor champion is born and our journey begins. The living donor champion is an important role carried out by a family member or a friend of a transplant recipient, and this can actually be multiple family members or friends. We want our patients to focus on their health. As healthy as they can be, getting to transplant is going to help their post-op and obviously their outcomes as well. They're going to continue working with their champion, so letting them know how they're feeling, updates that they may have in their journey. And the champion is going to take that information, share it with the masses to be able to create the awareness for a need for living donor kidney transplant. Patients face many barriers when it comes to living donor transplant. The first is really the fear of asking. We know as transplant professionals that these patients are really embarrassed by their situation. They don't like talking about the need for a kidney or that they need a transplant or that they're sick every day. This is really something that keeps those conversations from happening. We pair that with physical components, right? They tire easily. We see them in the units 3 to 5 hours a day, 3 days a week, with just 1 day in between treatment. And that is really tough on a patient. They really have a difficult time being able to have these communications because they're just not feeling well. And certainly lack of knowledge plays a part. These patients, sometimes they don't really understand the transplant process or really even their kidney disease. And they really want that continued education and support to help them navigate the transplant process. And really a very frequently asked question is, I don't know who to ask. Sometimes it's a husband and a wife team and they're like, this is all we've got. We have each other. We don't have kids. We don't have family members. And we know that that is definitely a struggle, but that is somewhere where we are able to sit with them, chat with them, and help them navigate how we can ask more people. Along with these barriers, patients face many challenges. So we know that listing day is a very emotional time, and they are provided a substantial amount of information. When you pair providing somebody with a bunch of information while they're suffering from things like depression and anxiety, right? These patients are facing organ failure on a daily basis. It is not an easy road for them, and that depression and anxiety can make that really difficult and create that brain fog that makes it hard to retain and process. And then, of course, their physical components come into play as well. A living donor champion is really able to come up with a patient and help them navigate these barriers and challenges to help them through to transplant. So what is a living donor champion? Question of the hour, right? I tell my patients a champion equals an advocate. This is an individual who's going to come alongside a transplant patient and share their personal story with others to bring awareness to the need of a living donor transplant. In this, they become a patient spokesperson. So we are so hopeful that they are going to be comfortable having word-of-mouth conversations and using some online platforms as well. And really what this is they are an educator, right? Here in this room, we are transplant professionals. We understand what patients are going through on a day-to-day basis. People outside of these walls really don't know what a patient struggles with every day. So this is where that champion comes in, and they are educating people through conversations about living donor transplant. UT Southwestern is an amazing place. We've got excellent results, short time to waitlisting, as well as a short length of stay at the best hospital in DFW 7 years in a row. And as you can see, it's a beautiful facility. Now we have this unique addition to our living donor kidney program in the Living Donor Champion program. We are the only transplant center in the North Texas region with a dedicated coordinator helping patients navigate their journey to transplant and beyond. How are we benefiting these patients? So we know that patients need a pretty substantial amount of coaching, and they are receiving that coaching from our entire team, but specifically from me. I am coaching patients and their dedicated champions on how to communicate the need for a living donor transplant. We are guiding these patients and their families step by step through the process, right? We know that it's a very emotional time, and sometimes they just need that little bit extra to get through. Empowering patients and their champions to learn as much as they can about living donor transplant, right? We want them to be comfortable having conversations. We want them to be able to share that education and knowledge with others. And I really just try to motivate them to help them share this messaging, but they'll, oh, Taylor, you want me to post 2 or 3 times a week on social media? How am I going to do that? Well, we're going to provide you with education. We're going to provide you with training, and I'm going to help you navigate social media with anything that's going to be efficient and providing that extra bit for those patients and their champions. And finally, just inspiring patients to be comfortable with living donor transplant. There are patients that I speak with that they really aren't comfortable with living donor transplant, and we're able to talk about it and sort of navigate those waters and help them to be comfortable knowing that they can get a kidney much faster and get off the wait list sooner. How are we impacting change? So patients and their families come to the Champion program with a very wide range of knowledge and skill set. Some of them are very proficient with social media, others need a little more assistance. So we bring them in and we bring them to the Living Donor Champion education session. And this is really where we educate and train, but we also explore options for creating a donor awareness campaign. And then we really take that bit of education and training and we continue to support them on their journey to finding potential living donors, because as we know, continued education and support is something that patients are really looking for. And then lastly, our overall goal is to get recipients to transplant as soon as possible, right? Getting off that wait list and getting transplanted as soon as we can. So how does this work? The first step is the patient must be formally listed here at UT Southwestern and receive their initial education. From that point on, their transplant coordinator will enroll them into the group education session. Laura was talking about this, Navigate the Wait. So that will be hosted by Dr. Levy, myself, and a donor coordinator. After that, I contact the patient and we begin the Champion education. So again, with who can help you spread the word. And my preference is really that we have the patient and the champion at this initial education session together so that we get the messaging, we can answer any questions. Sometimes it's just the patient and sometimes it's just the champion. There's no right or wrong, but I do like it when they come together. And then I give them a little bit of time, right? We've talked about so many things and some of them leave and they're like deer in the headlights and they have no idea how they're going to move forward. Others are like, let's do this, I'm ready tomorrow. But we then together build the plan for a donor awareness campaign. And once we get that awareness campaign set in stone, we take that champion and we just encourage them to share it as far and wide as they possibly can. Because again, it's educating others about living donor transplant, right? And then also creating that awareness for a patient's need for a living donor transplant. Starting the conversation is just, sometimes they are like, what in the world? How am I ever going to do this? Let's just start simple, right? Get with your group of family and friends that are your core people and practice with them having these conversations. Make sure that you have all of the tools in your tool belt that you need to be able to do this effectively with people outside of your core group. So they go and they practice with their friends and family. And then it's really time to spread that information to the masses. So community groups, faith groups, hobbies, wherever they can connect with other individuals is really where they need to start sharing these. And what are we sharing? Again, it's the patient's personal story, right? Everybody wants to know sort of what's going on in that patient's personal life, the types of things that they're going through on a day-to-day basis. Those are important for people to catch that and try to understand what they're going through. Providing those facts about living donor transplant to get more people thinking, oh, yes, we have 90,000 people on the wait list for a kidney and I could be a living donor. Great, okay. And then information on kidney disease. Again, there's lots of different kidney disease. Some patients may be well versed in what their kidney disease is, others maybe not so much. But so we have them, they've got this information and it's time to spread the word. Online resources are incredible. Social media offers endless possibilities. Facebook, Instagram, YouTube, TikTok, Twitter, Threads, LinkedIn. I could go on and on and on. There is a platform for everyone. We've got younger champions that are like, oh yes, I love Instagram and Snapchat, or I absolutely already have a TikTok and we're on it and we're using it. Perfect. Most of our patients are like, oh, I'm not so sure, what should we really, okay, let's start with Facebook. Pretty much everybody has a Facebook with at least on average 100 users. So social media offers them the opportunity to be able to spread that word as far and wide as they possibly can. And then we've got, non-digital outreach. And I like to tell them this could be considered like passive marketing. You're spreading the word, but you're not really having to have those one-on-one conversations. But thinking of things like stickers on cars, or this husband who's walking down the street with a sign that says kidney for wife. And I personally have had a few Gold Star husbands who have really reached out and done a tremendous job for their wives. But it's this level of creativity that sometimes they're just not thinking of it initially. So we have these conversations and we're able to really curate a campaign for them that is custom to them. Inspiring patients to build their community is an important task. Each transplant patient and caregiver deserves to have a strong community to support them through the journey to transplant and beyond. But for me, it's much more personal. It's the connection with transplant families that matters most. This brother and sister were born 19 months apart at the former St. Paul Hospital here on UT Southwestern campus. He was born with a rare birth defect. They just didn't know it. He faced significant health complications and years of sickness without any diagnosis. In fact, many misdiagnoses. Chronic illness was a part of everyday life, but he always remained the fierce protector of that baby in a bonnet. At age 7, he was diagnosed with bilateral grade 4 hydronephrosis, a non-functioning left kidney, bilateral reflux, posterior urethral valves, and a non-compliant bladder. His first major surgery was not long after to insert a suprapubic tube to attempt to assist his bladder. Ultimately, this surgery was unsuccessful. At age 8, he underwent a simultaneous nephrectomy to remove the non-functioning left kidney, bladder augmentation, and Mitrofanoff procedure, where he was then able to self-cath through a vesicostomy. These really produced extended hospital stays, multiple home health visits, and school bullies that were endured for years. During his senior year of high school at the age of 18, he received a living donor kidney transplant from our dad. That's right, that's my brother, and that's me. This was the first time that he had felt good for an extended period of time in his entire life. Can you imagine? The day my brother was diagnosed was the day the world's greatest advocate was born, my mom. And while she didn't know it at the time, she was shaping another advocate alongside her. She learned everything she could about urology and nephrology long before the days of Google, making sure my brother received the best care. She built our community, family and friends, and the most amazing care team of doctors and nurses. She actually made these beautiful works of art for the man who saved my brother's life the first time. Together, we navigated many dark storms. His first transplant worked beautifully for 9 years, give or take. And in early 2012, a harsh reality came knocking. I was in before they could say go because a second transplant was definitely on the table. We were lovingly considered twins for most of our lives, and on this very special day, we learned that we are what we coined genetic twins with a perfect match kidney. As soon as I got the call, I had my mom drive us to his dialysis unit, and there is the end result for that. In early 2012, he dealt with pseudomonas, multiple blood transfusions, renal failure, PD catheter placement, and initiated hemodialysis as I underwent testing. I'm not sure if you can tell this about me, but I'm a bit tenacious. He was listed, I believe, in April. I was in eval by June, and we were transplanted by August. 11 annual dinner celebrations later, with many more on the horizon. It is the connection with transplant families that matters the most. Knowing that feeling, and until you know that feeling, it's powerful. That's what keeps me showing up for these patients. It's whether it is the very beginning or if it is reigniting the flame to push them through to transplant. Excuse excuse me, that feeling matters most because it is what is helping them be confident to share their stories and to find themselves a living donor transplant. Thank you. Questions? My not favorite
Thank
part?
you, thank you, thank you, Taylor. Great talk, great talk. So your first question is, as an advocate / champion, do you visit dialysis clinics to educate patients?
I do not visit dialysis clinics, so I am utilized really once they are formally listed here at UT Southwestern. Miss Yuvani will be helping in the dialysis clinics, and we work very closely together. So what you hear from her, you'll hear from me.
Okay. Next question, are you going back and meeting with those patients who were listed prior to the creation of your position?
I am.
Okay. And I believe that's it for the questions. Thank you, Taylor. Y'all give her, oh, we have a question here. Oh. Aw, no question, just saying hi. Ah, well, thank you, Taylor. I appreciate it. So we're excited to have our most dedicated and hardworking social workers that we know of. We're going to give it up for Monica Lopez, Anjali Patel, and our kidney transplant social worker, Jennifer Nixon. Thank you. Oh, and I'm sorry, let me correct that. Jennifer is our living donor social worker. Get that right, Jennifer. Thank you.
All right, well, good afternoon. Thank you for coming to Psychosocial Aspects of Kidney Transplant. So today we're going to discuss basically who we are in terms of social workers in the transplant department. We'll talk about why social workers are in transplant and review the components of the psychosocial assessment and some of the contraindications for transplant based on the psychosocial assessment. Living donor social worker, other elements of the role, like other things that we as social workers in transplant do besides evaluations, the social determinants of health, also how we work with the multidisciplinary team, the physicians, other nurses, APPs, that sort of thing. And at the end, we'll have some time for question and answers. So who we are. Basically, this is the list of all the social workers in our transplant department. We have cumulatively of almost 50 years of experience in transplant altogether. We do have experience outside of the transplant world, varying from child welfare, domestic violence. Most of us have worked in the hospital as discharge planners in various roles. Transplant donor services, disease management, and even some probate court. So why do we have social workers in transplant? Well, partly because it is mandated by CMS, the Centers for Medicaid and Medicare Services. It's also mandated by UNOS. A lot of insurance companies require that you have social workers in transplant. But we are there basically to ensure that a patient is appropriate for transplant. They have everything they need. We are trying to be good stewards of a scarce resource, and you may already know this, but organs for transplantation are really scarce. So we want to make sure that we're, doing our best to make sure they're going to be well taken care of. Our job is to bring patients into the transplant program, not to weed them out. So we work really hard at looking at all the positives, their protective factors that they may have, to help mitigate risks that they may have. We look at different opportunities where we can provide them resources or kind of bolster up what they've already got. If it's a little squishy, we want to work with them on their finances, tell them to, try to budget, save money, that kind of thing. If they don't have caregivers or caregivers that aren't, that lack a little bit, like maybe not have transportation, we help them try to look at other caregivers to kind of bolster that up and use as many people as they need to help them get through the transplant process. We remain unbiased. We're one of the for these evaluations for patients, take everything into account in terms of what they have for transplant, and we just try to maximize their outcomes post-transplant, help them be the best they can be. So these are the components of the pre-transplant psychosocial evaluation. We ask a lot of questions to try and get to know the patients. We ask them about their family of origin, their family of creation, most of whom will end up being their caregivers. We ask where they're born and raised and their level of education, just to kind of gauge their understanding of the entire process, and a description of their childhood. We touch on mental health history. We look at that to see if that would affect pre or post-transplant outcomes. We ask questions about cognitive impairment or developmental delay, just so that we can tailor some of our education so in the best way for them to understand. We look at military service as well to see if they have any service connection and can utilize some of the VA resources that are available. We ask about housing and transportation. You might not know this, patients can't drive for a few weeks after transplant, so we have to make sure they have somebody available to provide that transportation or look for backups for the post-transplant transportation to and from their home, whether it's close or far. We look at their criminal and legal history just to see, make sure that there aren't any issues that could come up at the time of transplant or post for them. We ask about substance abuse, any addictions, which would also affect their ability to care for their transplant, for their new organ after transplant. We also discuss insurance just to make sure that it's adequate. And there's other programs that are available that we utilize, American Kidney Fund or the Kidney Healthcare Program, to help kind of bolster that if there's a little bit of lacking, you know, in their coverage or in their available finances for post-transplant medications. We also review requirements of the patient and of the caregivers and the responsibilities post-transplant. So we review all of that with the patient just to make sure that they understand what's expected of them post-transplant. And sometimes we ask that a patient come with their caregivers to the initial evaluation. That doesn't always happen. So we usually have to have a follow-up visit and have their caregivers come just so that we make sure we're looking eye to eye, we're telling them exactly what the expectation is and making sure that they can meet that. And if not, we work with them and trying to figure out what else they can do, who they can talk to kind of bolster that as well and make it a team effort on their part to provide support for their patient. We also look at, they can bring 3 or 4 people and maybe they're available, but maybe they wouldn't be able to provide that support. They might not be that functional. Like you can bring 2 people and if they don't drive, then we need another one. Or if they're working full time and they're the only wage earner in that family, we kind of work with them, okay, who else can we tap into to help provide your support while your wage earner continues to do that? We also look into their diagnosis history. We ask them, you know, what caused their kidney disease, trying to get their insight into their disease process and maybe what role they played in that, if they are not taking their medications correctly or something like that. We ask them about what they understand about the transplant process. They are given, you know, education, they see videos, but sometimes we ask that question, what do you understand? And then we fill in the blanks. We try to help them engage them into the transplant process and so they can know what to expect. And one of the other things we do is we ask about their motivation for transplant. A lot of our patients show up and they're convinced they have to have that transplant, but why do you want it? Well, my doctor told me I needed it, or my family's really pushing me. So we just try and flesh that out and see if they really want one. And there are occasions where we have patients that don't really want it and they're not ready. That is totally fine. That's what we're there for. We want to ask them about that. And then we tell them, it's okay, we can do this again when you are ready. We also look into their adherence, not just to dialysis, but to medications, to diet, showing up to appointments in clinics. Their adherence prior to transplant kind of leads into how they're going to do after transplant and their adherence with their medications and appointments. So one of the tools that we use for our evaluations is the SIPAT. This is the Stanford Integrated Psychosocial Assessment for Transplant. This came out of the Stanford Transplant Program, and it was developed by a team led by a psychiatrist, Dr. Jose Maldonado. They did a comprehensive literature review, and we're looking at transplant outcomes and how psychosocial aspects affect that. It helps us with standardizing the evaluation, identifying subjects or patients that might have negative outcomes, or it clues us into problems or areas that might be problematic for them. But it also encourages us to, once it shows us those parts that might be problematic, it helps us to zero in on that and work with the patient to try and fix some of that, look at different ways that they can improve. The findings that we have on these, there's a score assigned, and sometimes that is actually highly predictive of the transplant psychosocial outcomes. So other elements of the role, one of our biggest roles is doing the psychosocial evaluation, but we do quite a bit of other things. We provide, like I said before, we provide education to the patient and to the caregiver as often as they need it. We always open up ourselves for phone calls, MyChart messages, whatever they need, and we'll provide them with information about the process or about what we do, how we can help them. We do PRN consults, mostly for the outpatient patients. We follow them on the outpatient basis, and if they have any issues with food insecurity, with medication affordability, with transportation, we provide them with resources and work with them to get them what they need. We also do paperwork for them, FMLA and short-term disability. We don't do the Social Security disability. That's different. We just guide them in how they can tap into those programs. We troubleshoot complex cases if there's anything going on, like this is not unheard of, where a patient has a whole plan in place and they get to transplant or after and things fall apart. They lose their transportation, their housing is going to go away, they're going to lose their insurance coverage, or their caregiver, for whatever reason, is no longer available. So we work with them and try to figure out what we can do, how we can be flexible in helping them to be successful. We do offer a support group on a monthly basis. It's on a Zoom. Anybody that's interested gets that Zoom link, and it's open to all of the organs, heart, lung, kidney, and liver. There's also a mentorship program available. So we get some patients that want to know more about transplant or somebody else's experience, or they want to know, how they can navigate that. So the mentorship program identifies patients that are willing to be a mentor for others, and they receive training, and they're also informed it's not medical, they don't give medical advice, and we make sure that they establish boundaries, and we match those patients with a mentor that's kind of similar to them or that can help them out. There's also an online Facebook page for transplant. And we also have an internship program for graduate students, for graduate social work students. There was a pause on that for COVID, but that's getting started again. We also provide peer education. We do CEUs for others and for other disciplines if they ask. We participate in transplant selection committee. And then we provide information from the psychosocial evaluation to help the committee make the decision to list. We participate in post-transplant rounds at the hospital, discussing patients that came in for transplant and any barriers they might encounter that might hinder their discharge. And we'll work really quickly with the family and with the team to help them. And so there are social workers that do work in the hospital on the transplant floor, but our roles are very different. So they assist with the discharge planning. They'll set up home health or equipment or dialysis if needed after transplant. We focus in on, do you have your insurance coverage? Can you afford your copays for your medications? Making sure you have that caregiver or the transportation or lodging after you leave the hospital. So there are some contraindications for transplant from the psychosocial perspective, and some of those can revolve around their support. Their support has to be stable emotionally and socially, being available. If they don't have any support, that's a really big deal for transplant. So that might be a contraindication if they don't have it, but we do work with them trying to figure out who they can tap into to be a caregiver for them. They have to demonstrate their ability to adhere to the medical regimen, continuing their dialysis or their diet or showing up to their appointments. If that's an issue, we just give them time to kind of work on that and get better at it and then come back to committee. We also work with them on financials. We do ask about that just to make sure that we're not hurting them financially to give them a transplant. Some of the medications they go home on can be a little costly, so we just try to make sure they have appropriate finances. And we kind of give them homework sometimes, like maybe you can go home and work on a budget, start saving, fundraising, just to kind of help you out, especially in that initial post-transplant phase, where they may even have to cover their own lodging if they live farther away. We also, if they have a mental health or mental illness would not keep them from having a transplant, but if they have untreated psychiatric disease or active suicidality, that would be a contraindication. We would make referrals, get them the help they need, and then bring them back. If they have any active substance abuse, that might hinder their ability to care for that kidney after transplant, so that would be as well. We do ask that patients be nicotine-free prior to listing. So we have quite a few patients that may be smoking, using tobacco products. We do put them on hold until they can get kind of, clear of that 6 months, and then they can be listed. We also look at any kind of cognitive impairment or memory loss. We do additional testing if required. We refer them to a neuropsych evaluation just to see where they are, and if we have to tailor, certain things, education and that sort, to help them be successful after transplant. I'm going to go ahead and pass this to my colleagues, Anjali and Jennifer. You're going to see some case studies where there's going to be a QR code at the upper corner. If you click on that, it's going to open it up for some questions or some polling, and you can get their real-time answers. And this is for all of you and for those people at home.
So as Monica said, social support is very important post-transplant. As indicated by research, social support has a direct and significant association with post-transplant quality of life. We have a case study. So this is Nathan. Nathan's a 50-year-old African-American male, first evaluated for transplant in January 2021. He is developmentally disabled and he's dependent on family support. Prior to transplant, during the pre-transplant phase, he was excellent with his dialysis adherence, and then his mom and his uncle were his primary support people. He was transplanted in August 2021. With this case, what would be some of your concerns, or how would you move forward, or would you move forward?
So this is where we would really like, can y'all hear me okay? I'm gonna live over here. We really would like some engagement. We have Yvonne accessing the poll for those that are participating at home, but we really were hoping for engagement. I know I learn when I'm participating in a symposium of sorts, I really learn the most from case studies. So we thought maybe this would be something y'all would be interested in as well. What would y'all's initial concerns be with this information? You can take it virtual with the poll and the QR code, or you can just say it out loud. I'll repeat anything that's said. Anybody want to be the first one? What you got? Health of the mother and the uncle. Perfect. Let's see. Yvonne, you have continued family support, dependent on family support, understanding of transplant, aging and ability to continue to provide care. Y'all are all like hitting it, right? These are the things that we also had concerns about. Do you guys need to move anything? Okay, sorry. These were some of the same things that we also had concerns about. Would y'all move forward based on this information that you have now? Is there anything that flips your trigger that says, ooh, maybe not? Feel good about it? 80% yes, 20, 22, okay. Ultimately, it was determined we did not have enough based on the information we had to not move forward, right? So let's click over. So we know we work with people and things happen. Mom died. Uncle did not have primary caregiving afterwards, was not the decision maker, was not who our patient went to live with. He went to live with his brother, who was not the primary stakeholder in the workup and initial phases of this patient's care. Sometimes that's how it works. What happened in this case is we had to get brother caught up to speed, but still uncle and brother had some disagreements on how the patient's care should go. We tried to bridge the gap, get the brother some additional education. Let's get home health in the home to add some extra layer of support. He did not let home health in, but ultimately we did extra teaching with that patient and family in the clinic to try to close that gap. We know we work with people and things happen. Life happens despite the best efforts and intentions. And these are some cases that we, to the best of our abilities, try to have you think about ahead of time. We're likely in all of these situations going, What happens if? What's the chain of guardianship? We know we have cognitive difficulties here. We know we have decision makers, but what happens if mom's not with us? Who's next? And are they already caught up to speed? Best laid plans sometimes means that we have those conversations with them in eval, but it really is up to them to determine if that's something that they plan for once they're no longer in front of us, right? Do they go back home and actually make those plans, and then how do they play out long term?
So we always also look at mental health history, if there's any presence of psychopathology, current versus historical, as well as the severity. We look at their coping skills, maladaptive versus adaptive. You know, if there's any self-harming behavior, substance use versus the adaptive, if they've reached out for help, you know, journaling, anything. Closer to the mic, sorry. Any of those adaptive coping skills. In those cases, if we feel like patients have any sort of maladaptive coping skills or any severity, any current, you know, suicidal or recent suicidal ideation, any concerns for mental health, we'll make a referral to our transplant psychologist. Sometimes we may make a referral or, you know, suggest that they link up with outpatient therapy, and we can make those referrals as well as needed. For patients with substance use history, we will refer to addiction psych. For contraindications, you know, we consider if it's uncontrolled, severe psychiatric illness that raises significant concerns about an imminent safety risk to the candidate or others, or ability to adequately care for him or herself. You know, for patients with depression, you know, there's a twofold risk of graft failure and return to dialysis for post-transplant patients. Any poorly controlled psychiatric disease can also result in infections, readmissions, and medical costs. So our next case study is Elizabeth. Elizabeth is a 57-year-old African-American female evaluated for transplant in December 2021. She's a high school graduate. She has some college. She had Medicare Advantage for her insurance. She was single but in a long-term relationship, living alone locally in Irving, on disability but uncertain of her disabling diagnosis at the time. She did have a history of depression, on medications, but did not remember any of her medications. Her medical records indicated that she had a diagnosis of bipolar depression, but she denied it at the time of evaluation. She was referred to our transplant psychologist, and she was labeled as moderate risk candidate for a history of depression, mild anxiety, and then eating disorder. She was eventually approved for a listing. What are some of your concerns, or would you move forward with this patient?
QR code is there. If anybody wants to say it out loud, happy to take that feedback. What would your initial concerns be in this patient's case, in Elizabeth's case? Mental health? Medication adherence? Would y'all move forward with what you know? And if not, why? I saw a couple of heads shake no. Would you be so brave to say why? Right, you're thinking the long-term care partner may serve as a protective factor for her. Right, so what she's saying is additional education. Is there some insight gaps? Is that kind of a quick summary? Is there a gap in her insight into her history of health? And is there something that can be a bridge that can be, a gap that can be closed? Okay, agree. Okay, so let's go over what her outcomes are. What do we see? Are we seeing maybe the manifestations of her mental health coming out in this acute, stressful situation that is transplant index hospitalization? Likely, right? So what do? Whenever we have someone like this, likely we've picked up some flags in the eval, and we've likely included a referral to our mental health colleague, psychiatry, psychology. Anecdotally, if I see a psychiatry colleague or psychology colleague stating moderate risk, for me that means watch and monitor and have a low threshold for looping them back in, especially during that index hospitalization and that peri-op period, because we may see some things that were not kind of glaring or apparent when they were on their stable dialysis regimen and in their normal routines, right? This is one way we see things that may have been stable and kind of under the radar You may see that patient and describe them as maybe quirky or a little challenging here and there. Some of those things, when you put a new organ in and they went under the knife and they're in the hospital, they're all there all at the same time. But you can see she actually got on medications and she's doing okay. So still a win. We moved forward with her. There was nothing that kept us from moving forward with her, but she needed extra help, and that's okay. We have those services here. We want to include our colleagues to partner with us and get them the extra support that they need.
Adherence is a very important piece as well when we're doing our initial evals prior to transplant. We will request dialysis logs. I'm sure you guys have received phone calls from us for those logs. Just because non-adherence is often viewed as the extent to which a patient's behavior coincides with the prescribed medical plan of care. It is complex and multifaceted phenomenon occurring on a continuum of adherence, partial adherence, and non-adherence. Just some of the predictors of non-adherence, prior non-adherence behaviors, such as with dialysis, we look through the records to see if there's medication non-compliance, any psychiatric illness, personality disorders, substance use, abuse, low levels of received social support, avoidant coping behaviors, high education level, personal mastery, adolescence. We see it with a lot of our younger patients where they struggle with the medication compliance piece. And then living alone and any financial stress as well. Our next case is Oscar. Oscar is a 59-year-old Hispanic male evaluated for transplant in February 2019. He had Medicare A, B, and D. He completed the 9th grade in El Salvador and then received his GED at 18. He was married at the time of eval, living with his wife in Carrollton, and he was last working as a truck driver, but was on disability at that time. During the evaluation, he was adherent to dialysis. There was nothing indicating non-adherence. What are your concerns with this case, and would you move forward?
Anything that you think would be a whoa, or what would your concerns be, if at all? Does anybody have any concern with his case? And I'll look behind you, Bonnie, too. What you got? She mentions insurance after he's been transplanted. So the 3-year timeline, right? Okay. But anything that would keep y'all from moving forward, yes or no? You can do head shakes. Probably not, right? Financial status, literacy of the patient, language and education. All of these things would likely, in his case, not be a barrier because it hasn't been a barrier, right? He's been doing the deal. He's been doing his dialysis. There's been nothing that would make you think he wouldn't continue to do that after transplant. Okay, what happened? Bum, bum, bum. He showed up. When was he transplanted? May 2020, height of COVID pandemic. And we probably all have an understanding of kind of what that means. A lot more virtual. Doesn't mean it goes away to nothing, right? He still has to come into a hospital. There's still real people taking care of him. It's just COVID was a different era of care. Presented for transplant, divorced with a girlfriend. Where did wife go? And then the wheels fall off the bus. We say that a lot. I don't know if y'all use that terminology. We say wheels fall off the bus because it kind of gives you a picture of the bus had wheels and then they didn't. And it gives you kind of a what came and what can we do about it. 1 week later, after discharge, he presented to the outpatient clinic requesting medication reteaching. Okay, let's do it. Let's get you that reteaching. Well, we no-showed our reteach with our pharmacist. Post-op day 11, presented to the emergency department with an acute kidney injury, not taking meds secondary to the side effects. Okay, so maybe some insight lacking there. We don't understand maybe fully what the side effects mean. Can we talk about it? Is there something that we can do differently instead of just not taking your medicines at all and the importance of that? 2 months after transplant, returned to the emergency department with right foot osteo, refused amputation and left against medical advice. Multiple readmissions, eventually had a right partial foot amputation, still not doing his meds. December 2020, lost insurance, secondary to premium non-payment. So yes, you got it on the insurance. It just happened earlier than we expected. It was another reason that he had his insurance lost. Refused calls from social workers. All right, how many times is a social worker, like y'all are usually like the last ones to get pegged after the nurse has probably tried to call 10 times, right? Like by the time we are the ones calling, it's like, oh shoot, we've had so many people before us that have also probably tried to call and it's just not going great. Lost to follow-up, returned to dialysis 1 year later, May of 2021. Fun fact, he has reapplied for transplant as of September of 23. Was the wife the reason it happened for him? Maybe. Was she the protective factor? Did she keep things together? Did she remind him of his appointments? Did she make sure his dialysis transportation was a non-thing, a non-issue to be worried about? Maybe. Yeah, so for those at home, we have one of the social workers here that mentions cultural competence, the kind of the matriarchal potentially aspect in this patient's case.
Next, we assess for substance use. So any history of any nicotine, illicit substance use, marijuana, alcohol. We assess how often, how long, how much, when the most recent use was. If there's any periods of any abstinence or relapse, if they've received any substance use treatment, any cessation. I think Dr. Levy previously talked about tobacco or nicotine cessation for some of the patients, and then consequences of use. Has it affected them socially, legally, medically? Any impact to their medical treatment plan? Of course, in those cases, any patients with severe use or when we have concerns, we'll make those referrals as needed. Any history of abuse does not automatically preclude listing, but we want to implement any interventions ahead of time so that they have long-term success. Any contraindication is usually absence of active substance abuse. So our next patient is Dwayne. Dwayne is a 65-year-old Caucasian male evaluated for transplant in March 2018. He lives alone, high school graduate with some college. His caregivers were mainly his niece and his sister. He was on disability, unknown what the disability diagnosis was. He did have a substance use history, but denied current use at the time of evaluation. His prior labs indicated positive meth use. He did, at some point, post-transplant, he reported emotional and reported bugs crawling on him. Police were notified by the coordinator because she had concerns. A wellness check was completed. He was seen by psychiatry while hospitalized and provided with resources. He did eventually follow up with psychiatry, and it hasn't yet had any further follow-up since then. What are your concerns? Would you move forward?
I feel like there's one word on there that most are probably focusing on. And I'm curious if y'all are focusing on the same thing that I focused on whenever I saw it. Okay. So for those at home, the meth use is what one of our audience members mentioned, and that sticks out to me as well. Some of those at home lives alone, substance use, drug use, support, disability diagnosis, lives alone, support, a lot of the same theme, right? Mental health, substance use, support, finances. This is kind of the picture of multifactorial psychosocial risk, right? Ultimately, would y'all move forward with what y'all know? Bum, bum, bum. Okay. This individual, by the time he was transplanted, had met sobriety expectation, but what happened? There was some risk that he took into transplant, and some of that risk unfortunately played out after. Sister called us concerned, ultimately resulted in a welfare check, presented to the ER, bugs, skin crawling. Curious how he turned out? Stable, family support engaged. He is now connected to psychiatry follow-up and pastoral counseling and doing well. I feel like this is like one of those Lifetime movies, right? Like there's the picture and then the oh no, and then but it's okay. So this patient got the support that he needed. Sometimes it takes the really big kind of final straw that broke the camel's back to really understand something has to go, something has to change. And sometimes that transplant could be the catalyst, unfortunately. But sometimes that's the way it happens. We just have to understand the need, have a patient buy into the need being real, and also buy into what it takes to improve their situation. And thankfully, this gentleman got the support that he needed and is doing well.
Right. Finances, insurance, and work history. So how do we talk about affordability with prior to transplant? We ask patients about their work history, sources of household income, income versus their expenses, insurance status and ongoing access to healthcare, access to short-term disability, FMLA, long-term disability, as well as if they're utilizing any community resources or have any financial assistance or history of finances impacting adherence, any disability history, as well as we have a budget discussion and review of potential costs. We go into the finances just because that is very important. We don't want to cause more harm than good with patient. I think Monica touched on this previously. If there's been history of finance access that's affected, attending appointments, access to their medications prior to transplant, and then we increase that with all these medications we're going to be getting them started on for transplant, we're just going to do more harm than good at that point. We talk to them about, say if there's any savings in place, budgeting. Sometimes some people have family members that can assist post-transplant. So we assess how long can that happen? How long will they be able to support them financially? Just because, there are no fixed transplant comes with costs beyond cost of care. If they're struggling now, that could only increase post-transplant. So too poor for transplant. Right now, the cost of transplantation in the U.S. is covered by Medicare, Medicaid, and most commercial insurance plans. But the insurance landscape is changing. And so we've got the cost breakdown per organ. And for kidney, currently it's listed as $250,000. And then for immunosuppressive medications, for any patients that are uninsured, could cost up to $35,000 per year. And then you have to consider the insurance co-payments, which can be about $7,200 to $14,000. We try to ask patients if they're enrolled in Texas Kidney Healthcare and American Kidney Fund. Those are good programs for them to be enrolled in prior to transplant. We do make sure we educate patients on American Kidney Fund that assistance is not long-term. It will end within the year post-transplant. So we always want to make sure that they're aware so they can plan financially of how they are going to manage those costs of the insurance premiums post-transplant. So right now, research shows that those living in poverty or uninsured are less likely to receive a transplant no matter how far we've come. Like I said, we try to mitigate some of those things. There are patient assistance programs, but those are being for the medications, but those are less and less as we're seeing. We try to make sure they're enrolled in Texas Kidney Healthcare, American Kidney Fund to offset some of those costs. We look at other resources, sometimes GoodRx, those kind of things. We try to look at different resources to manage those. So legal status in transplantation. It's one of the most frequent questions that we get asked. So what is out of status? An out of status individual is someone without U.S. citizenship, permanent residency, or a documented status that permits living in or visiting the U.S. So a patient may have come in on a work or travel visa, but it's no longer valid. Being out of status can often compromise their ability to renew a visa, obtain another visa, or even travel to and from the U.S. in the future. There is a 180-day rule that states persons who have been out of status in the U.S. For 180 days or more are unable to be legally permitted in the U.S. until they have remained outside of the U.S. at least for 3 years.
So when Angela says that we get this question a lot, just know it's not from this setting that we get asked that, because we know it's something that y'all see in your own patient population. The question of out of status as it relates to transplant is a very ongoing discussion, even within nationwide, like all the national conversations, right? I just got back from conference where it's literally just transplant social workers, and we're all talking about how do we do this, how can we do this, and what supports are in place to do this. Some states are easier to have supports in place, like the protocol process. Texas is not one. So we have a couple of examples up here as to kind of what we may see on referral and what the risk may be for that individual person. So we'll start with one. Victor had a work visa at some point, but is now out of status, but has an ACA plan for insurance and is applying for transplant. So when you have a work visa, you can sign up for healthcare.gov ACA plan. If your work visa lapses and you go to renew, you're not guaranteed renewal for that ACA plan. And in the state of Texas, what is your out for insurance coverage and your access to healthcare? These are the very real dilemmas that anytime any one of us has a patient out of status or is on the fringe of having it or not, it's not an isolated, I figure it out by myself. We're constantly staffing it with each other saying, okay, is there an option or for this patient to have access to healthcare if they received a transplant? Like we go all the way down the road. If they get a transplant tomorrow under their current insurance, if they're under a work visa and don't go back, if that ACA plan lapses and we can't get them a new one because they don't have a work visa, where do they go for their care? Because we can't see them here. So if they live in Dallas County, Parkland will see them. Thankfully, we can get them their transplant meds. If they're Tarrant County, JPS Connections doesn't allow for out of status as a full JPS connection. So that's just, I mean, I know this is very nitty gritty, but these are just very real conversations that we have on our side of how do we get them what they need. I hope this helps kind of answer for any of the patients that you have in your clinics or the people that you're seeing of like when you refer them, please refer them. We want to try to get those to transplant that have options for long-term access to healthcare. But just in case y'all are wondering when they don't get to move forward, some of the things that we talk on in real time when we see them. The next one is Debbie has a valid work visa, which is to be renewed every 2 years. However, she has not worked in the past 1.5 years due to dialysis. So it's kind of the same situation, right? She had a very real access to health insurance, and then that means of access to health insurance is no longer an option, or she's not currently enrolled in an active work visa.
So our next case study is Rosie. Rosie is a 46-year-old Hispanic female. She was born and raised in El Salvador on a family farm. Didn't have any formal schooling, unable to read or write in Spanish or English. She immigrated to the U.S. in 1999 and had family in the Dallas area. She had a work visa and she was working in housekeeping and food service. She had ESRD, Medicare, and Social Security disability. And then she was eventually evaluated for transplant in November 2014. She was listed for transplant in 2013, but removed in January 2014 due to insurance issues. Support was local family and oldest child were to provide post-transplant support. Her sister was also involved in the eval. Psychosocially, she was considered high risk secondary to out of status. She was approved for listing in January 2015 and received her kidney transplant in August of that same year. She returned to work after transplant and then lost Social Security. Would you move forward with this patient? What are some of your concerns?
So for the sake of time, because I know we have a few more slides and we want to get to it. Anybody that has big reservations that would or would not move forward with transplant? Yes, no? Immigration, communication barrier. So we'll go to what happened to her. I know her intimately. I used to be on the kidney recipient side and she was one of my patients. If you look at the date that she lost that ESRD Medicare coverage, I know one of y'all mentioned earlier that was a concern for a previous patient. It's on the nose, 3 years on the nose that she got her transplant, that ESRD coverage fell off. She did not renew her work visa when she returned to working, and we know she lost her Social Security. So she is also Tarrant County, and what does that mean? JPS Connections cannot fully absorb her, so she was compassionate. Ultimately, she had a JPS social worker that worked with her intensively. Her supports fell apart. Ultimately, they were intermittent, had a friend, cousin, sister, kid, but not consistent. And she had a very hard time navigating systems, a very, very hard time navigating systems. She was able to work with the social worker at JPS and got her residency status clarified, and she is back on outpatient dialysis with ESRD Medicare.
So criminal history and transplantation, I'll just touch on this. It's not our job to hand down a second sentence or charge. That is the job of the justice system. So individuals with criminal history are due consideration with concern, being for access to medications and care for those of imminent incarceration risk. John is a 39-year-old Caucasian male evaluated for transplant in December 2022. He's a high school graduate, had some college, not married with 2 daughters, arrested once in college for evading arrest. His SIPAT score was a 13. What are your concerns? Would you move forward?
Probably not a lot there that you wouldn't move forward on, right? As Anjali mentioned, our job is not to punish again for something that is not in our roles. 100% yes, they would move forward. Okay, what happened to John? Unfortunately, he was not totally forthcoming. And while the information on the right side would likely not have resulted in us not moving forward, we likely still would have moved forward. However, it removed the opportunity for the social worker to give strongly encouraging words to maintain your connection to your PO. Do not let that fall off. Even if you're in the hospital for transplant, you still have an obligation to a PO, and we know the risk that comes with not maintaining that reporting. Ultimately, we were able to get that parole officer a letter. They accepted it. He's fine. But this is not to say we wouldn't have moved forward if we knew the stuff on the right. It's to say we lost an opportunity to really strongly encourage this individual to maintain good standing, maintain your reporting. Transplant is not your get out of jail free card. Like, quite literally, that does not mean you get to not be incarcerated if you do not do your other aspects that you're expected to do from the court system.
So social determinants of healthcare and health literacy. So social determinants are, factors such as socioeconomic status, education, neighborhood, physical environment, employment, and social support networks, as well as access to healthcare. We do consider these things as social workers. We look at health literacy as well. There's a study where it says gross illiteracy is with excellent graft survival in renal allograft study. For patients with any health literacy concerns, we want to work with those patients post-transplant. Make sure we're asking open-ended, teach back, simple and easy. If they speak a different language, we want to make sure we have a translator available. Ongoing education, just reinforcing that post-transplant. So I'm meeting with the pharmacy team, with their post-transplant coordinators to make sure they understand their medications, allowing them to ask questions, and just being person-centered with that patient. So this is Ire. Ire is a 44-year-old Burmese male. He's Burmese speaking only, evaluated in April 2021. At the time of the eval, he opted for his friend to translate over a certified translator. He moved to the U.S. in 2011 and became a citizen in 2016. He was married at the time of eval, but his wife actually lived in another country in Bangladesh, and he lived locally in Texas. His SIPAT score was 12. What are some of your concerns? Would you move forward with this patient?
Anybody that would say yes or no? Anybody that would move forward? Yeah, a couple of head nods. Any big concerns? Language barrier, family support not readily available? Valid concerns. What happened with Ira? Received kidney transplant in June 23. We learned during post-op period teaching that he was illiterate in Burmese. That's okay. We worked around it. Y'all do the same thing in dialysis, right? It's not uncommon for a patient to not speak our language or be literate in our language or theirs, or their native language. There's plenty of tools available. Our pharmacists work with them on what is your best method of learning your medication regimen. In this patient's case, it was using pictures for medications and discharge teaching. Taught secondary and tertiary caregivers. We know we don't always ask that patients have like 5 layers of support deep, but in some cases, it may be necessary to have the multitude of layers of caregiver support. Is it your neighbor? Is it your longtime friend? Is it a strong church member? We'll teach them if that's what it takes to get you the support that you need. He's stable with functioning kidney.
So I'm going to hand it off to Jennifer now.
I also do living donation. I do heart transplant on the other side, but living donor for the abdominal side. I also do psychosocial evaluations. The unique aspect about living donation is we are not here to sacrifice one for the sake of the other. It's probably the easiest way for me to say that. That would make sense. There is kind of a church and state, right? I am the living donor social worker. They are the recipient social worker. We do not cross over for a reason because my obligation is to my living donor in front of me to do my due diligence and allow them the opportunity to share their history and making sure that they are going to be successful long-term after donation. That's ultimately the goal. We don't want to take their kidney or in some cases part of their liver for the liver side, only for them to not be successful. So what are my contraindications? Uncontrolled psychiatric disease is probably the biggest concern. I've seen a lot more post-pandemic than I did pre-pandemic. We're all seeing that. We have resources here. We have 2 psychologists on our campus in our psych clinic that see our donors in the context of giving away an organ and a history of mental health disease. And then support. Again, we don't want to set our donors up to not be successful. So it's important to have a support that is separate from the recipient support. So that's a lot you can think for a caregiver to be both. And if you think if a donor is a mom giving to a dad and it's the daughter, that's a lot of pressure on a daughter to care for both. So we do ask that they have separate caregivers. A lot of what I do for our donors, majority of the time, the donors are, I hate to say clean cut, but they come with low risk. They're interested parties that want to give away a piece of their body. So generally, it's a population that feels that they're probably in fairly good health, not unanimous, but majority. But there are some that come with areas that they would benefit from shoring up. I work with them for resources. One of the biggest programs I have that I think is helpful to know for the recipient side is the NLDAC, up to $6,000 benefit. It is based off recipient funding or recipient household income. Has to be approved before surgery. They have to live in the United States and be citizens and residents. So that's a couple of pitfalls of that program. But last year, $57,000 was a benefit to my living donors. This year, it's 61 and counting. I put asterisks at the end because surgeries and benefits often occur outside of the year that they were approved. One case study, I'm just going to go ahead and go through this quickly. This is a case of a 24-year-old female wanting to donate to her child who was at our children's center or hospital across the street. She was very motivated, right? It's a mom that has a young kid. She wants to give him her kidney. She wants to see her kid be a kid. However, psychiatric disease picked up an evaluation, and we asked our psychiatric colleagues to also see her to give further insight and recommendations. And here's the diagnoses that they found her to have after their evaluation. What happened is we initially turned her down because, again, separation of church and state. I'm a mom, and this was really hard for me because I have a 2-year-old and she had a 3-year-old. And I'm like, you're trying to tell me if I had mental health disorder, I can't donate to my child. That's tough. That's really tough. We all would feel the pull of wanting to allow her to do that because there's benefit. She gets to see her kid. However, if you're looking at the 4 ethical principles, autonomy, she wants to do it. Beneficence, she's probably going to benefit to some degree because her kid gets to have a better quality of life. But the non-maleficence, the do no harm, has an asterisk at the end of it because we don't know going into it with her psychiatric disease that we're not setting her up for not being successful. So it's not no forever. It's no, not right now. Let's work on that. Ultimately, she was reevaluated after mental health treatment. Support system connection is better, and she was ultimately approved. Does character content matter? I don't have a lot of time, so I want to make sure because the next few slides I can go over, but I want to allow good time for question and answer. Do I have time? I'll go through, here's personality disorders and transplant. There's not a lot of evidence of personality disorder, not a lot of research about personality disorders and transplant, but anecdotally, those that we talked earlier about when patients come to the hospital and get transplant and have a really hard time, those that ultimately are found to have personality disorders, they struggle. There's a little bit more challenges with those that have personality disorders. Okay, well, let's go here. What kind of questions do we have? Thank you all so much for participating today.
Okay, first question. I know we have 3 minutes. So first question is, what if the patient does not have a caregiver at the time of transplant? Do we assist with that? And are there any grants to cover caregiver needs?
No, there are no grants. What we typically do is we say, this is when you turn over every stone you've ever thought of. Is it your neighbor? Is it your friend from high school that you've maintained a relationship with? This is when you reach out to all those people that have said, let me know how I can help. Many times there's not really, I shouldn't say not really ever, but there's many times that it's not that they don't have any caregiver, it's that they have a really hard time asking. And we get that. Many of our patients, and similar to many of us, have a really hard time being the one that needs the help. We often like to give the help. And that's true for our patients too. So we walk them through, this isn't a forever need, this is a temporary need. And if they've already come to you and said, how can I help you? That's the support structure you need to tap into somehow. We're not asking for caregivers forever. It's like 1 to 2 weeks, especially for those that do really well. So we do encourage them to ask. It's the other version of the big ask. The other big ask is donation, being a donor for me. The other big ask is, can you be a caregiver for me to get me through this recovery period so I can go back and have quality in my life? But Medicare and Medicaid, Medicare doesn't cover caregiver, and if they have Medicaid, some patients come with attendant services, and that gets factored in a little bit.
Okay. Next question. If a patient has cognitive impairments due to a stroke, Do they qualify for a transplant?
Depends on the extent of the cognitive limitations and the support structure that's around them. Because I would say someone with a stroke, depending on the cognitive difficulties in their functioning, would not be very different from someone who had developmental delays coming into life. So those, we would assess the level. We would likely refer to neuropsych to get a full understanding of their opportunities or limitations. And then we would also do a very thorough support assessment and have that question or that discussion about what happens if primary caregiver isn't able to be there anymore.
Next question. When looking at compliance with dialysis, is the focus on treatment adherence mainly, or are there other factors strongly considered, such as IDT notes regarding non-compliance with diet restriction, medications, fluids, etc.?
Well, it's the whole picture. Ideally, it's the whole picture. Dialysis, actually making it to your sessions is important. But if you're not taking your medications and if you're not following through with the other lifestyle recommendations, then there's kind of not a total picture of adherence there. So it's not just one thing, it's kind of the global picture. I mean, I also work with heart failure patients, and you're not doing your medications any good if you're eating a high sodium diet and drinking all the fluids. So dialysis is only helping you so much if you're also not following through with the rest.
And last question, does Medicare Part B now cover immunosuppressants?
And Medicare, so it depends on if you're transplanted with Medicare as your primary payer at the time of transplant. If you're transplanted with Medicare as primary payer, all immunosuppressants go under Part B as in boy, where everything else remains under Part D as in dog. So that does mean that the way that it pays is different because D's deductible copay structure is very different from B. It's usually 80-20 with Part B. So it depends on what your primary payer is at the time of transplant. But yes, B as in boy covers immunos.
Great. Thank you. Let's give our social workers a hand. Thank you. Yes.
If you forgot me, I'm Scott Bennett. I'm the AVP of Solid Organ Transplant here. I'm happy to introduce our next speaker. So just like you are not going to confuse Yvonne with Helen, I trust that you are not going to confuse me with Yvonne. Yvonne's done a great job moderating for us today, but I'm going to try to fill her shoes here by moderating this session and allowing her to the podium. So Yvonne, come on up.
Thank you, Scott. Thank you, thank you, thank you, everyone. I applaud you all again for coming out today and receiving this information. So, like Scott said, my name is Yvonne Ford. Let me tell you a little bit about myself first before we get into all the business part. So I'm originally from a small town in South Carolina, Sumter, South Carolina. I'm number 6 of 7 children. My father was in the military. He retired from the Army, 29 and a half years Army, 2 tours in Vietnam. And good thing about my name, my mom got to name me what she wanted to name me because I was actually born while he was in Vietnam. I wasn't conceived while he was in Vietnam, but I was born while he was. I always like to get that straight. Let's get that straight. So I've been a nurse for a while. I started nursing when I was 2, so I've been a nurse for about 28, almost 29 years now. So about 32 years old, minus a little bit of gray. And I've worked dialysis in my previous careers, oncology for many years. I've managed clinics. I've been directors in hospitals. So I have a vast array of experiences. And guess what? I get to bring them all here for you and your patients. And I love it. So my role here at UT Southwestern, I'm the kidney dialysis liaison. I can now spell liaison since I've been in this role, so that's a good thing. I communicate with dialysis centers. I send out your monthly reports, which come via fax. You can use those reports for your quality meetings, for your IDT rounding. I educate staff and patients about our transplant process. I do lobby days. I actually send out the notification letters when your patient is transplanted. So I actually fax that letter out also. And then once the patient is discharged from the hospital after transplant, I also send out the discharge summary and op notes to the physician, the referring physician. So this is a question for you. Is knowledge power? Have you heard knowledge is power? How many of you believe knowledge is power? Okay. So I'm going to take that away from you today. Because knowledge is not power. It's the application of the knowledge that gives it power. So if you're sitting here today receiving all of this information, all of this knowledge, and you go back and you do nothing with it, guess what? No power is there. So some things we're going to talk about today is transplant important? We're going to talk about clinic transplant champions, monthly status reports, definitions, which is new, and I'm excited about that. Transplant lab compliance, and vaccinations. So let's talk a little bit about transplant. How many of you feel that transplant is important? Okay. How many of you feel like transplant is not important? We do not have to call security, so that's good. It's good. It's good. So transplant is important. How do we know? Because the network, the ESRD network, has transplant projects that you can work on at your clinic level. We worked on it when I used to manage dialysis clinics, and it pretty much opened my eyes more to transplant. Your company, we have different companies represented here. Your companies has goals for transplant, right? You have goals for transplant in your clinics? Yeah. And also transplant is important because it's potentially offering a better long-term and better quality of life than just staying on dialysis alone. You've seen the slides about that, and it's phenomenal what transplant can potentially do for patients. So just look at some of the goals and implications of transplant here. There are some incentives out there for preemptive kidney transplants, increased reimbursement for living donor expenses, encouraging collaboration between dialysis centers and transplant centers. Guess what? We're collaborating today. Dialysis centers are now judged on waitlisting rates, and that could drive in more referrals. So what are some of the goals here? 80% of new end-stage renal disease patients in 2025, the goal is for them to be receiving home dialysis or transplant. Does that mean the dialysis clinics are going to be totally empty at 2025 because this is here? Okay, you still have job security. It's okay. 25% fewer Americans developing end-stage renal disease by 2023. How many of you, what is the #1 cause of end-stage renal disease? This is a test. Diabetes. Diabetes. What's #2? I heard it. Hypertension. Put those two together and what do you get? So when they're saying that, I want you to think about yourself. I want you to think about your family members. If you or someone you know has diabetes, making sure that you're keeping that under control. If you have hypertension, it's called the silent killer for what reason? Sometimes you don't even know you have it. So you have to be getting your checkups. Okay, that wasn't a part of my presentation. So now why don't you allow UT Southwestern to help you reach your goals? How can we help you? We can handle any issues with your patients that you're being referred to us, that you're referring to us. Any issues with them, we're usually communicating. Myself and Helen are calling you with any issues, any concerns. If they're being re-referred again, we want to make sure that those issues that were the problem that got them off the list before, declined before, are already taken care of before we push that referral through. Let us help you educate your staff and your patients. When I actually come out to dialysis clinics to do lobby days, in the lobby, I'm educating patients. But guess what? Lunchtime, break times, I'm in there in the break rooms educating the staff also, doing some education about transplant. Some of you have been very good with like, okay, Yvonne, I got this person, she's interested. Can I send her out to you on her break? Sure, send her to the lobby. I'll get the education done. And let us help you lead your clinic to successfully achieving your goals. How do we do that? We plan these events. I've been invited to your quality meetings. Thank you for that. I appreciate it. I've been invited to regional meetings for social workers and for companies, and also corporate meetings. So we're here to help you. Let us help you. You should have in your handouts, everybody got some handouts, a folder with some handouts? Did you all get a little contact card that looks a little something like this? That has information on it on how to communicate with us. Very important information. And another thing I always like to say, let me make sure it's on there, new patient referrals, yes. If your patient needs to reschedule an appointment, it's okay. Just have them call and reschedule that appointment. It's not the end of the world, but please have them reschedule those appointments. The appointments for transplant are not meant to be an appointment on their dialysis day. However, if that's the only day they can schedule, please help reschedule their dialysis treatments. We don't want to cause any harm, so we want them to still get their treatments. Now, when we're talking about education, what are some reasons you would call me to see if I could do some education for you all? New social workers. I know several of you have called me and said, I have a new social worker starting. Can you please do a 30-minute information session about UT Southwestern? I'm always willing to do that. If you have an IDT training, please invite me. Love to do those. Any staff meetings, lobby days, and quality meetings again. Now, you've seen this graph already probably 3 or 4 times already today, so I won't go into it much, but just know that just being on dialysis alone is not enough. We've all seen those young, healthy patients, even the older, healthy patients that are coming in for their treatments day in and day out, week in and week out, decade in and decade out. I met the patient that I met a couple of months ago was the longest patient I've ever seen on dialysis. He's been on dialysis 35 years. Never had a transplant, walking, talking, looking good and looking healthy. And I thought that was amazing because before that in my clinic, my longest patient on dialysis was 25 years. He was in a wheelchair. He was already missing limbs, missing fingers. You know, to see that. But I also like to tell people dialysis is not the end all be all. You'll have those patients when I'm in lobby days say, oh, I'm leaving that to the younger ones. Let them get the kidneys. I don't want them wasting a kidney on me. Well, we wouldn't waste a kidney on you. You know, how much do you value your life? So wait time, Ms. Laura talked about wait time, average is 4 to 6 years, and the key here is dialysis time does count toward wait time. That is something that was not always the case, but it is now. So we have those patients when I'm in the lobbies that have been on dialysis for 10 years, and they say, okay, so how long is the wait list? And I'm like, for you, don't worry about it. Just fill out your application because you already have 10 years of wait time. So you'll be escalated through readiness so we can go ahead and get you an offer. The gold standard of transplant is living donation. How many of you have gotten that from the speakers before me? Everything is focused on living donation. I'm so excited that we have Dr. Levy here, who's very, very, very forward and ready to help people, living donors, get their donations going and getting transplant going. I'm happy that we have Taylor now here once your patients are waitlisted with us, and that's very important for you to understand. She's not coming to clinics to educate and help them find a donor before they're waitlisted. They have to already go ahead and apply and be waitlisted with us. And that's another added benefit for you all sending them to UT Southwestern. But we won't go there. So Mr. Scott, I always like to talk about Mr. Scott. Some of you have a Mr. Scott in your clinic. You see Mr. Scott here? He looks kind of pale, right? Y'all seen that kind of patient in there hooked up to the machine? Don't pay attention to the people not in their PPE, touching the machine without gloves on. As a manager, when I looked at this picture, I was like, oh my gosh, Giovanni, find a different picture. But that's Mr. Scott. So just focus on Mr. Scott right now. Mr. Scott is in the clinic, and guess what? I was in this clinic that day, and he talked to me about living donation. He had a daughter that actually wanted to donate a kidney to him. So he filled out the application, and he's kind of older. So he said, Giovanni, you know, they said since I'm above a certain age, I wouldn't qualify. Well, I told him UT Southwestern, we don't have an age limit because everyone actually goes through the evaluation phase to see if you're healthy enough to receive a kidney transplant. And he was like, oh, okay. So he applied. There's his kidney. So he traded in his dialysis needles for a kidney. Y'all see that? And look at Mr. Scott now. This is his daughter who actually donated to him. He's spending time with his granddaughter, his daughter. And these are the things that Mr. Scott said. He says, I feel like I'm going to live longer. I have freedom from dialysis. I feel better. I have a better quality of life. I can spend more time with my family. I can do work that I want to do and activities. I have less dietary restrictions. Guys, they get this kidney, they can drink fluids now. They can eat what they want to eat. He also said he had improved fertility and sexual function, so I asked him not to go into detail with that. He has improved anemia, ability to travel, and he feels like he's maximized his survival. So y'all give it up for Mr. Scott. So Mr. Scott is not a real patient. He's fictitious. I made all that up, and I found these pictures on the internet. So there's no HIPAA issues here right now. So let's talk about the IDT team in transplant. Social workers. Mostly, how many of you are social workers? Raise your hand. Okay. Social workers, most social workers have a ratio of 1 to 75 up to 100, but it can go up to 125 plus. Do y'all agree? Yeah, it depends on you. So a lot of times, most companies or clinic rely solely on the social worker to handle everything transplant. But I'm encouraging you to help make that an IDT thing, not just you. Get your other entities in there, your nurses. When you look at a nurse, their ratios are 1 to 8 or 1 to 12, depending on where you are. They can answer questions about transplant. They can do a little bit of transplant education for your patients. They can make sure that those transplant labs stay on track. And if the manager decides, they can actually add that to their evaluation to increase, hopefully, their pay. Let's look at the dietitian. How can the dietitian help? Dietitians, they have a high patient load. Their ratios can go up to 125 patients. But guess what? They can help with those patients with the high BMIs that can't even get on the wait list. They can help with the patients with the fluid management because the patients may have CHF and they may need to manage their fluid a little bit more to get their ejection fraction up so they can actually get waitlisted for transplant. When you look at the patient care tech or CCHT, we call them in the dialysis clinics, their ratio is about 1 to 4, 1 to 6. They have the closest relationships with the patients. Why? Why is that? This is the interactive part. Why do you think? They interact more with the patients. They're the ones sticking them. They're the ones putting them on the machines. They're the ones joking with them every day. They're the ones that may have the professional or non-professional relationship with the patients, but we hope professional. They can help focus on labs. Y'all have seen it. That's why y'all laughing. They can help focus on the labs and make sure the labs stay in compliance. They can help allocate a certain area in the clinic just for transplant labs. The reason I say that is because sometimes we're making calls saying, okay, this patient's labs were due 6 months ago. We still haven't received them. And I may be talking to the secretary and she said, we haven't received the kit. And then we send out another kit and I call back and this time the nurse answers. And the nurse says, well, we already have 3 kits. Why'd you send another kit? And I'm like, because they told me you didn't have a kit. So if you allocate a certain area in the clinic for labs, that helps everyone with lab compliance, but definitely the PCTs because they're the main ones usually drawing the labs. And the secretary, like I said, the monthly report is faxed to your clinics. Some of you have, talked to me about not receiving it, and we found that the fax were actually going to an e-fax to a social worker who left 3 years ago, and that's why you weren't getting them, but we've gotten all those corrected. But you can actually have the secretary pull the report from the fax, share it with the clinical staff, the nurse or tech, so they can actually see when the actual labs are due for those patients. How do you identify good candidates for transplant? Usually first shift patients are the best patients on Monday, Wednesday, and Friday. Why? Because they're driving. If they're driving, they're usually good candidates. They at least have one leg, right, if they're driving? I've had a patient, the reason I say that, I had a patient that was a bilateral BKA, and he was still driving. He would get out of his car, come in for treatment, and take his legs off and get in his wheelchair and come into the clinic, and everybody was like, how'd you get here? And he said, I drove. So it was a running joke with him. He thought that was funny. I didn't think it was funny because I was scared. But anyway, so those patients who are ambulatory, they're ambulating without assistive devices. They're motivated. They're excited. They're watching their transplant labs and keeping them in compliance. They're focused on their family. They're frequent travelers. They love to get out and about. And they keep their labs in range. So how do you get to build a relationship with your patients? How many of you feel like you really, truly know your patients in your clinic? Raise your hand. A few hands, about 5 hands, okay? You online, virtually, I can see your hands too. Just raise them up high, raise them a little higher. One thing that I always use to get to know my patients and even get to know my staff and get to know people in general is the form method. And I know this form has 2 F's, so you can stutter if you need to pronounce it correctly, or you can say that the second F is silent, but it's called form. Now, believe it or not, you all formed me when I came up to the podium. And I'm going to test you on that, okay? Form stands for, let's see if we have it here, from. Asking the patient or a staff member or whoever it is where they're from originally. Is everyone in Dallas or in your area or in your clinic from here originally? No, people are from all over. So find out where they're from. Where am I from? I told you my from. Where am I from? South Carolina. Y'all were listening. All right. So ask them about their family. What's their family makeup? You know, do they have children? Okay, you'll have some talk about grandchildren and have the biggest smile on their face. And they'll ask you, how do we have grandchildren and not ever have children? Because I like the grandchildren and not the children. I've never been able to answer that question. But family, what's my family makeup? Where am I in my family? Number 6 of 7. Y'all really listen. Number 6 of 7. Good. Occupation. The O stands for occupation. You can ask your patients what did they do if they're retired or what do they do, because a lot of patients still work. What's my occupation? What do you know about my occupation? Registered nurse. What have I done in the past? Oncology dialysis, yeah. And then we talk a little bit about what do they like to do for fun? Ask the patient, ask the staff, what do you like to do for fun? Did I tell you all what I like to do for fun? No, but some of you who know me know I like to travel, okay? And I haven't been traveling because I have a family. I'm starting to do it though, I'm starting to do it. And then the message, you use the message of transplant. After you've gathered this information, you use the message of transplant. So let's say it was me, I'm the patient in the clinic, and I come in and you've already formed me, and the message to me would be, okay, Yvonne, let's talk a little bit about transplant. I know you're number 6 of 7 children. I know you used to be a nurse, or you're still working, I'm not sure. And I know you like to travel. Did you know that once you get a transplant, you'll be able to travel a lot more and a lot easier? You don't have to schedule visits to a dialysis clinic wherever you go. Or if you're on home, you don't have to haul all of this stuff with you. And start really using that message of transplant whenever you're talking to people. So I want you to go out and start forming people. You can do it in Walmart, you can do it in the grocery store, you can form people in here today and they won't even know you're doing it. How do you celebrate transplant in your clinics? I know some clinics that I've been in, they have a bell, they ring the bell when they have a successful transplant. They post signs for patients to see. I saw in one clinic it had our 6th transplant for the year. It was listed up there. Some of them pre-COVID used to have the Walk of Fame because every patient wants to come back and show off their beautiful skin tone, their beautiful clothes, and come walking through the clinic saying, I got a transplant, look how great I look. And sometimes that helps other patients say, oh, well, if he can do it, I know I can do it. But when I was in a lobby day in this clinic, they actually had this up. And some of the patients thought that I brought it and put it up just for lobby day. But this clinic actually had on here all of the transplant listed, and it actually has the date of each transplant. And when I came in to do my lobby day, the patients were like, we've had this many transplants at this location? And the social worker said yes, and most of them were UT Southwestern. So you need to talk to that young lady over there. So they were like, oh, they came running over to the table. So applications, you all were familiar with our applications. They were about 2.5 pages long. Guess what? They're going away. Okay? Applications are going away. You actually have this in your little handouts. Okay? This is our new application. Patients get to read it. They decide they want to go with UT Southwestern. They put their name, date of birth, and signature, hand it to the staff at the clinic, and guess what? You process their paperwork utilizing our referral portal. Monthly reports, this is our monthly report. Some of you got monthly reports yesterday, some this morning, and they'll keep coming out for October, but this is what the monthly report looks like. And what I like about this is now, of course, I'm adding to it every time. We're adding more information that we feel that you would like to see on here. And I know Cheryl Kaplan, she hasn't been up here yet, but she's been really, really good at saying, Yvonne, do you think they need to know this? Do you think they need to know that? And we kind of tweak it for what we feel that you need to know and what the feedback is from you all. But you also have a monthly report definitions in your handouts. Do y'all have that in your handouts? Something that looks like this? It's explaining every column of the monthly report. If you read that and you still have questions, please do not hesitate to reach out to me. More than happy to help you with that. But the goal is to make sure you have everything you need. Labs, the goal is to make sure that the labs stay up to date. And on the monthly report, we actually have a protocols section up there, and it tells you when the labs are due. In the protocols, do you see over there, it says quarterly right here? This patient's labs are due quarterly. If it's blank right here, that means we don't have a time for it at this time, and it'll probably be coming on your next report. Let's move forward. Vaccinations is important to make sure that all patients have their vaccinations. I know in the clinics you work hard. We're just another layer here to help them understand how important it is to have vaccinations. Ms. Laura talked about delayed graft functioning, and that's when we have a sleepy kidney. That usually occurs if you have more so a deceased donor versus a living donor. And we know that living donation is the gold standard of transplant. Everybody agrees with that? Yes. All right. So in summary, we talked about transplant. It's important. We talked about making it a team effort versus just a social worker effort. We talked about the monthly status report. Now let's talk about your knowledge. You've received a lot of knowledge, right? So what's going to happen leaving today? Are you going to give your knowledge power? How are you going to give your knowledge power? You're going to do what? Share it. You're going to put some of these things that you've seen today in action. I want to thank you for allowing us to help you reach your transplant goals. Thank you for allowing us to share information with you today. And I'm super excited that you all got to be here in person. I'm loving it. Thank you.
So thank you, Yvonne. As you can tell, we've had to work really hard with Yvonne to bring her out of her shell. She's coming along nicely, I believe.
Thanks, Lee.
So several questions for Yvonne, but I think actually a couple of these are more appropriate for Dr. Wojciechowski, who's up next, who's our medical director. There is one question I think I can field here, and it comes with kind of a funny story. What is the age of the oldest patient getting a kidney transplant at UT Southwestern? The oldest patient I recall, and this may not be scientifically accurate, so Dr. Wojo can correct me, but I do know we transplanted an 82-year-old several years ago, and I remember seeing him several years later when he was 89. And I said, "How are you doing, Mr. So-and-so?" And he said, "My kidney's great. It's just the rest of me that's breaking down." So to our earlier point, we will consider patients at advanced ages and they can thrive and do well. So I'm going to switch seats with Yvonne and give her back her chair after she introduces Dr. Wojciechowski, our medical director.
All right. Thank you, thank you, thank you. So up next, we have a treat for you. And the treat is our medical director, Dr. David Wojciechowski. Excited that he's here with us. He's brought many innovative programs and initiatives, and he brings a tremendous amount of energy to our program. So we're going to try to hold him back a little bit, but bring him on up, Dr. Wojciechowski. Here you go, sir.
Thanks, Lonnie. I think last year they put me after Vonnie, and I think I requested not to be because can anyone live up to this? I don't know. Scott, I think you're right. 82 is the oldest I can think of that I've been since I've been here. And you're right. We don't have an age cutoff, just so everyone knows. So send anyone of any age. But you'll hear about the things we look at. That's what I'm going to talk about, the elements of post-transplant success. And really, what I'll be focusing on is what did we do for that workup to get them ready for transplant? And you heard some of what Avani said is going to be sort of repeated in my talk, but I'll be giving you a little more nuts and bolts about what we look for kind of on the medical side. But if you're a reasonably healthy 82-year-old, except for your kidney failure, we'll give you a transplant. And as Scott said, it is true. I actually will sometimes say to patients, your replacement parts are doing great, but how's the rest of you? And that is true. That tends to be what happens as they get older. But anyway, so, this is a very typical patient that we would see in our transplant clinic. 66-year-old African-American gentleman, long-term diabetic, hypertension for 15 years. He has a little bit of obesity, high cholesterol, prior smoker, blood type B. not yet on dialysis, CKD 4, GFR is 19. So we've all seen patients like this, right? Slightly older, couple medical problems, and they want to know what they should do. Should they start dialysis? Should they be referred for a transplant? What's their best course of action? So if we're thinking about sending a patient for transplant, really the questions you want to ask yourself really are, what are the goals of the transplant? Why do I want to even transplant this person? What are we trying to achieve? And I'd say with any transplant, for the most part, there's two overarching goals that you're trying to achieve. And one would be increase the length of their life. And number two would be to improve the quality of their life. So whenever you evaluate somebody and you want to try to achieve those elements of post-transplant success, we always ask the questions when we see that patient sitting in front of us, are we reasonably able to achieve both of these goals? Is that something that we can do with this patient with a transplant? So the data on survival actually, believe it or not, took a while to show in transplant. This was a paper that came out in 1999. And this was really the first time that people showed a survival benefit with transplant versus dialysis. This was looking at a group of patients listed for transplant who were on dialysis. The dotted lines are the patients who remain on dialysis. The solid line are the patients who underwent their transplant. And you can see that actually early after transplant, you have a higher risk of dying than you do if you stayed on dialysis. And why is that? We see that with any operation, right? If any of us go in for a gallbladder surgery, for example, we have a higher risk of dying from the perioperative risk than we would have if we had not had that surgery. So you see that same thing with a transplant operation. You take on that early post-operative perioperative risk in that first 90 to 100 days. But once you get past that perioperative period, you can see the survival curve goes way down compared to dialysis. So meaning you have a much lower relative risk of death with the transplant than you would have if you stayed on dialysis. And in fact, the relative risk is about 0.32 at 18 months, far lower than what you'd see if you had stayed on dialysis at that point. And this is more modern data. This came out in 2018. And this is looking at similar things. So a group of patients listed for transplant who are on dialysis. The dotted lines are those who are still on dialysis. The solid line are those who were transplanted. Again, you see that early postoperative mortality risk. Your risk of dying goes up slightly after you have the transplant, but then once you get past that perioperative mortality risk, again, your relative risk of death goes down, way down compared to remaining on dialysis. And if you look on the right, this is sort of what gets to the heart of the question about age and things like that. It's looking at different categories of patients and what their survival is with a transplant compared to dialysis. And you can see that pretty much across the board, you actually improve people's survival with the transplant. As patients get older, and I suspect this is why someone asked the question about the age cutoff, you do start to see that, that bar across the one, meaning some patients you help, some patients you may not help live longer. So you may not always get that survival benefit with the older patients. So that sometimes becomes a more case-by-case selection decision, looking at their overall picture. So that is something that may end up coming into play when you're seeing an older patient as something that may rule them out if you think they have too many comorbidities that you may not really help their survival with a transplant. But again, in general, we typically help survival after transplantation compared to remaining on dialysis. This is some data looking at quality of life. This was a cross-sectional study. It looked at about 76 transplant patients compared to dialysis patients. And then also looked at the general population. And basically, they gave them quality of life questionnaires and asked them questions about things like their physical function, pain, their overall health perceptions, et cetera. And the general population patients who are the control were in the black bars. The darker gray bars are the patients who underwent transplant, and then the lighter gray are the ones who are awaiting transplant. So those are the dialysis patients. You can see that the patients who underwent transplant have scores that are quite similar to what's seen in the general population. So overall perceptions of their quality of life have certainly improved after transplantation compared to remaining on dialysis. And then this is looking at the cognitive function of patients post-transplant. This was a smaller study, but it looked at just about 30 patients who were stable with renal failure on dialysis. They underwent some testing and assessments while they were on dialysis. And then 6 months after transplant, they underwent the same testing. And what they showed essentially is circled there that they had improvements in cognition after transplant, particularly in the reversibility of memory problems that they had associated with their dialysis treatments. So there is not only functional improvement and perception of improvement, but also cognitive improvement that you can see after transplant. So I think we can improve quality of life and also lengthen the life in patients if we do transplant versus remaining on dialysis. So when can you refer? I'm sure you've heard this already. But our messaging typically is, please send us your patients when their GFR is 25 or less. Per UNOS policy, however, we can't list them until their GFR is 20 or less or they're on dialysis. That is just the rules, but we like to get them a little early, because if we see them early and we have them kind of hooked up with our coordinator, the minute they have a GFR of 20 or less, if they otherwise met our listing criteria, our nurses can get them listed for transplant so they can get their waiting time accrued. So the important thing to remember about the way you can list someone for transplant is, I can backdate dialysis, but I cannot backdate GFR, except with one exception, and I'll talk about that in 1 second. So what that means is, if you send me somebody who's already been on dialysis and they've been on dialysis for, say, 6 months, I can actually use that dialysis start date as their transplant listing date, so they get that time credited. If you send me somebody whose GFR is 15, they're not yet on dialysis, but they've had a GFR of less than 20 for a year, unless they're African American, and I'm going to talk about that in a second, I can't gain them any time. So they can only get listed with the date at which I see them, not from their GFR of being 20 or less, maybe a year ago, something like that. This year in 2023, UNOS changed some of the rules, so some of you may have heard about this. So as you know, the equation used to calculate GFR historically had used a race variable, so African American versus non-African American. And that variable in some newer data came out to be not as accurate as equations that did not use that as a variable. So meaning the GFR was found to, the GFR equation that used the race variable was overestimating GFR in African American patients. So let's say an African American patient whose GFR in the old equation that used race was 25, the real GFR in the new equation may actually be 20 or less. So there was some concern that some patients maybe could have been referred sooner if they were African American, because the equation made it look like their GFR was higher than it really was. So in 2023, in January, UNOS put into place a policy that does allow you to backdate GFR for African American patients if you can show that the GFR was greater than 20 with a race-based equation, but less than 20 with a race-neutral equation. So the newer equations that we're all using now. And whenever we list someone for transplant based on GFR, we use the race-neutral equations. We don't use any race-based equations anymore for transplantation. So that is one caveat. So if you have an African American patient that you send to us who's already on dialysis, but they've been getting renal care for maybe 2 years before they start dialysis, they may actually get 2 more years of waiting time if we can show some of that data. And we had many patients, as we were allowed to go back and recalculate wait times, we've had patients gain 2, 3, 4 years of waiting time because we were able to get that data. And it really helped patients get transplanted a lot more quickly than they otherwise would. So keep that in mind, but we can only do that for African American patients because the equation was only using that as a variable. So other patients don't fall into that category. But that's why it's important to get them referred to us early so we can get that time credited and get that clock starting for the patients. So our patient JM does get referred to us for his transplant evaluation. So what does that look like for him? If he gets referred for a transplant evaluation, gets listed, what is he facing? So this is national data. This is not Texas data or DFW data specifically, but this is just looking nationally at the transplant database. So this is looking at what happens to patients 3 years after they've been listed for transplant. And these are patients who were listed between 2015 and 2017. Essentially what you see in that purple line, almost 40% of patients 3 years after being listed are still waiting for their transplant. So I think that's a really kind of sad statistic to quote. I think what's even sadder, however, is if you look down lower, if you look at that turquoise line, and then you look at that sort of gold line, those are the patients who either died waiting for their transplant or were removed from the transplant list because they became too sick. And you can see that number is almost 30% if you add that up. So the vast majority of patients 3 years after listed for transplant are still either waiting, died, or were delisted because they became too sick. So anything we can do to shorten the waiting time for patients, I think, is of benefit to them, because we know, and the data shows this, the longer you wait for your transplant on dialysis, the more likely it is you're probably going to die waiting than actually get the transplant. So anything we can do to shorten the waiting time, I think it benefits these patients, which is why Ivani rightfully said that we all know that the best transplant is living donor transplant, right? Because we can do that quickly, we can often do that preemptively, and patients get the best outcome in terms of how long the graft will last, and they certainly wait the shortest amount of time for that transplant. So what are the factors when we're considering a patient for listing for transplant? What do we take into account? And sort of what are the elements that we're looking for in these factors to have good post-transplant success? Well, this kind of breaks down into two things, and we're a little unique in this concept. If you've interacted with other transplant programs in the DFW area, we sort of have this concept of what we call listing criteria versus readiness criteria. So we have set the bar very low to get someone listed for transplant. We kind of default to give the patient the benefit of the doubt and just let them get on the list, right? So we're trying not to put up too many barriers to get somebody on that transplant list. Then we have what's compared to that is the readiness criteria. So this is then somebody who has waited some time, or maybe they have a living donor who has applied. And now we really want to get them through all the testing we want to get done to make sure that they're ready to go to actually get that transplant and make sure that transplant's successful. So let's look at these two different sort of phases or sort of categories. So our listing criteria is actually quite simple. I know this looks complicated, but believe me, this is actually quite simple. So just to get on the list, simple things. Did you go through the education session? Did you watch the videos, or did you come in for the lecture? Have you met with everyone you're supposed to meet? Did you sign all the consents you were supposed to sign? Do you actually meet the UNOS criteria based on CKD criteria or being on dialysis? Do you have a reasonable life expectancy of 3 or more years after transplant? So meaning you don't have anything that's going to rapidly progress that we think will shorten your lifespan after the transplant. Do you have good support? I'm sure you will have, or have already heard from the social workers about the psychosocial assessment that we do pre-transplant. Do you have the insurance coverage to be able to help cover the transplant and pay for the expenses? Are you cancer-free in the sense of any active cancers that are still being treated or require additional ongoing therapies or assessments? Do you have any active infections that are still being treated that would be worsened with the transplant? Do you have any psychiatric illness that needs to be stabilized prior to going forward with the transplant? Any active substance abuse? So for us, substance abuse, by the way, does not include marijuana, just so all of you know. So if you have a patient who's smoking marijuana, that is not a rule out for us. However, cocaine, that would rule you out. And we actually are pretty strict about tobacco, believe it or not. And most of that comes from the fact that we know tobacco is a very modifiable cardiovascular and renal failure risk factor. So if a patient is smoking and they're not yet on dialysis, we typically will list them inactive and give them 6 months to quit. If they're already on dialysis, we usually ask them to come back after they've quit smoking. And the reason we do that dialysis versus not dialysis is, as I already said, you can get your dialysis time credited back, so you're not actually losing your waiting time. Any conditions that we think won't improve with the transplant? This is kind of broad category, but one thing that comes up a lot that you'll see on this list is the obesity, BMI. So if your BMI is over 45, our algorithm of screening and scheduling would rule you out on the front end. So if your BMI is 45 or greater and you refer us that patient, it's probably going to kick it back to you and say that this patient, is not a candidate. If the BMI is less than 45, we'll see them. If it's 40 to 45, we actually typically won't list them. We'll refer them to bariatrics or one of our medical weight loss clinics that we have here on campus, where they're using a lot of the new drugs that are available, and then often can avoid surgery. Because our goal BMI, just so all of you know, is 40 or less. So that's what we're trying to achieve for our patients. And most of that honestly has to do not so much with the medical outcome, it has more to do with the surgical outcome. It's a much higher risk surgery in terms of surgical complications, hernias, wound infections, things like that. And then it also is more challenging to do things like biopsies after transplant and care for the patient. So we certainly know that it's a bit of an arbitrary number, and I'm sure other programs in the area have different cutoffs, but that's our cutoff, is a BMI of 40 or less. And then patients do have to get some lab tests obtained when they come in for their transplant listing and evaluation. Very simple things: chemistry, CBC, serologies, and confirming their blood type on 2 separate blood draws. So I think it's a very low bar. It's pretty simple. So it almost honestly is, if you eyeball well and have good supports and have insurance and meet the criteria for CKD or ESRD, we're probably going to list you for transplant, barring anything else that may pop up in that initial evaluation or listing appointment. One thing that we do look at quite a bit when we see these patients for the initial evaluation, I do want to bring this up, is frailty. This has come out in the last, I'd say, 5 or 8 years in transplant as something that really people focus on. There's a formal score that you can use that looks at things like unintentional weight loss, grip strength, walking speed, their level of exhaustion, as well as your activity level. And you can score these and then give patients a score, and then you can determine them to be either frail or non-frail. Why is this important? Well, it's important because we know that patients who are frail, which are those in the dark solid line, have a much higher waitlist mortality than those who are non-frail. We also know that post-transplant, if you transplant a frail patient, which is seen on this figure, if you go to the right, you look at the short and long-term outcomes. What you know about a frail patient after transplantation is they have much higher healthcare utilization. They have more postoperative delirium and complications. They tend to have more immunosuppression and tolerances, meaning they don't tolerate the drugs. And then that leads to increased mortality, increased death-censored graft loss, more cognitive issues, including Alzheimer's and dementia-related issues, as well as immunosuppression dose reductions, which contributes to graft failure. So frail patients, the long and short of it is, don't do well with transplant. Now, some people mistake this to think that when we say frail, we mean old patients. That is not true, actually. So anyone can be frail. A 45-year-old can be frail. A 45-year-old with bad diabetes, with an amputation, who is wheelchair bound, that's a frail patient. A 75-year-old who plays golf 3 days a week, plays tennis, and has PKD and no other medical problems and is still working full time is probably not a frail patient. It is true that the older the patient group gets, the more enriched that group becomes with frail patients, but it's not exclusively something that's limited to older patients. So we assess this in all the patients regardless of the age. We look at them. I will say we don't do the formal testing, to be totally honest with you. Typically what we all do in my group, we will often walk the patients in the hallway. We'll have them I will often ask patients to do a squat for me. You'd be shocked at how many people can't do this. Believe it or not. And then, I'd say one of the big things that happens is, you ask them to get on the exam table so you can examine them, and they say to you, I can't get up there, doc. Like, okay, why not? Well, I can't get up that step. Okay, so we know that's a bad thing. So there's kind of easier ways to kind of eyeball frailty without doing the formal assessment, but it is something that we look at. So this comes up quite a bit in our initial evaluations. And then actually it does come up when we see people for the readiness visit as well, because now they've been waiting a few years on the list, and sometimes someone that looked okay 4 years ago has now declined in their health. So our patient JM, unfortunately, he has no living donors, so he gets seen in our evaluation clinic. The doc that sees him thinks he looks pretty good. No absolute contraindications to getting him listed from that list that I showed you. So he gets presented, and 1 week after his evaluation, he gets placed on the deceased donor waiting list. No additional testing is required at that time for him. We don't require anything else to be done to get him listed. And basically what happens now is his coordinator, who's assigned to him, does an annual check-in by phone to see how he's doing. We make sure he hasn't developed any new medical problems that may need to have him seen sooner. We make sure that he still is interested in transplant. We check in with him again about possible living donors, see if anyone has expressed interest, give him some tips and tools on how to navigate that process, and just basically do a overall sort of general health check. Then what we do, based on a patient's blood type, so we look at our average wait time by blood type, and we keep an eye on that every quarter to every other quarter. And we look at how long are patients waiting for transplant based on their blood type. So as you know, for kidneys, they're primarily allocated based on waiting time. And then the next main driver is what your blood type is. So we look at our average wait time by blood type at our center. And then when we are within a year of that average wait time per different blood types, that's when we begin the readiness process for patients. So this patient is blood type B. Our blood type Bs right now are waiting on average about 4 years for an offer. So he's 3 years in from his waiting. So that's when his nurse is going to start getting him ready for transplant. So this is where we actually want to have the patient undergo the readiness testing and have that readiness visit. So I'd say the two main categories of testing that are assessed at this visit are what's circled there. So you have the cardiovascular testing and then the health maintenance or the cancer screening, I'd say is the better way to put that. Those are the two real sort of big ticket items that we're looking at when we're trying to get a patient ready for transplant. And why is this important? So this is looking at patients who are listed for transplant. And this is looking at the death rate per 100 patient years. What is the primary cause of death in patients waiting for transplant? All of you know this who are working in dialysis units. It's cardiovascular, right? These patients have a very high burden of cardiovascular disease. And you can see that these bars are different time points. So starting in 1980 all the way up until 2007, you can see cardiovascular has remained since the 80s as the primary cause of death in a patient waiting for transplant. What about after we transplant them? What's the primary cause of death? Well, it remains cardiovascular. So that's in the dark bar again on the bottom. And you can see it's been anywhere from 35 to 47% of our patients after transplant die of a cardiovascular event. So we know that cardiovascular screening and assessment of these patients is very important because it's the main driver of their mortality pre and post-transplant. So we view the cardiac testing as a true preoperative testing, right? Meaning we want to do the cardiac testing to get them ready for the surgery and to get them ready for that transplant. We have not found that there's really any value in doing cardiac testing to list somebody for transplant, particularly knowing that they may have 3-4 years to wait for that transplant. There's plenty of data that's out there that shows no benefit in testing an asymptomatic patient for cardiovascular disease. So we really view it as a true preoperative assessment. And we don't do any annual testing for patients either to keep them on the list. We try to do the cardiac testing once and done and do it as a way to just get them ready for that transplant procedure. So the guidelines from KDIGO, which came out in 2020, do recommend that asymptomatic patients should undergo some testing. So I would say that all of our patients who are on dialysis are probably at high risk for cardiovascular disease. So we typically will get some form of non-invasive cardiac testing in all of our patients. You may ask then, well, what is the best test to get? Well, the short answer is they're all probably pretty good. So this is a meta-analysis that looked at multiple different studies. It looked at a nuclear med stress test, that's the top group, a DSE, dopamine stress echo, and then bottom is actually angiography, so left heart cath. And it's looking at the all-cause mortality in these patients post-transplant. And you can see that positive tests, so positive nuc med stress, dopamine stress echo, or cath, did have predictive value of predicting post-transplant mortality. So if you had a positive stress test and you went forward with that transplant, you had a higher risk of all-cause mortality post-transplant. Same thing holds true for major adverse cardiac events. That's what MACE stands for. All three tests were able to predict post-transplant major adverse cardiac events if they were positive. So positive tests, I think, are very important to understand and know about because we'd really like to move forward with the transplant getting those tests from positive to negative, right? So if you have positive stress tests, we'd like to do something to try to make that stress test negative, right? So have a cath, maybe get that LAD lesion fixed or whatever it may be. What's the best test to predict events? That's an interesting question. This study actually tried to answer that. It's an older study, but it's one of the only studies that I've seen where they actually put all their patients through all three tests and then said, well, which one worked the best? So what they found actually was that angiography was actually the best. So that's in the bottom right. So if you had a single vessel lesion of 70% or greater, that had a very high predictive rate of showing post-transplant cardiac events, even more so than a nuc med stress test or dopamine stress echo. So, and this was a group of patients who were labeled high risk for cardiac events. So these were like diabetics, long-term dialysis patients, things like that. So what's our protocol? So we do a little bit of risk stratification. So low risk, meaning non-diabetic, a little younger, very few cardiac risk factors. So pretty much everyone then will get an echo and an EKG. If you're at moderate risk, so again, a non-diabetic, maybe older, a couple cardiac risk factors. In addition to the EKG and echo, we're going to get a stress test. And obviously, if that stress test is positive, we're going to proceed with a cardiac cath. High-risk patients are a little more complicated, and I think there's a lot more controversy about what to do with these patients. So if you're diabetic long-term, so we define long-term meaning type 2 for more than 10 years, type 1 for more than 20, 25 years. If you have PVD, long-term dialysis, which we say more than 10 years, which luckily we're not seeing many of those anymore. We're getting those patients transplanted. But if you have a high-risk patient, we often will just refer the patient to cardiology for that heart cath directly and skip the stress test. Because the data shows that cardiac lesion is probably more predictive of events anyway. And you have a high risk in these high-risk patients of having a false negative stress test because they may have balanced ischemia, meaning they have multivessel disease that may not actually show up on a stress test. So as you know, the way a stress test works is it's looking for imbalance of perfusion. So if you have lesions in all three of your major cardiac vessels, you may not have an imbalance of blood perfusion with that stress test. So you may actually end up with a false negative test. So we often will just refer these patients directly for that cath as well as getting the echo and the EKG. And then if you've had prior interventions, cath, CABG, et cetera, depending on when that was, we may need to get another stress test or echo or stress, dopamine stress echo or nuc med stress. If it's been a while since you've had anything done, we may even just get a cath in a patient like that. So if it's been more than 2 years, we may want to just get a repeat cath. But if they've been revascularized within the last year, we typically will just go forward with that transplant without any additional testing at that point. So that's the cardiac piece. So that's a lot of our focus when we see patients for that readiness visit. A lot of my doc's time is spent looking at all that test result, getting that into the chart, into the note. So when the patient gets called in for transplant, whoever calls them in and looks at that patient's chart, we can easily see all that, see that it's all been done, and make sure that everything has been tied up in a nice little bow. So the second big category that I wanted to touch on is the cancer screening, which I'd say is the other big piece of what we're looking at in that pre-transplant assessment. So why is this important? This is an interesting one because if you look at cause of death again in transplanted patients, cardiovascular, as I mentioned, was number one. If you go back to the 80s, malignancy was actually pretty low down on the list in terms of what caused their death. So that's the light gray bars in each of these larger bars. But if you go forward in time, cancer takes over from infection as the second most common cause of death. So if you look in the 80s, infection was up there as the second most common cause of death. Why was that? Well, we didn't have Valcyte back then. We didn't have the knowledge to prophylax against pneumocystis, right? So patients were dying of these opportunistic infections in the 80s that we just didn't quite have a handle on how to manage or how to prophylax. Now we do, and we don't see patients dying from these things anymore. We still see these infection events occur, but it's pretty rare that we would see someone die from one of these events. Now cancer has become the second most common cause of death. So it becomes important to sort of screen for this pre-transplant to make sure that we're not missing anything on the front end. Now you may ask, once you put the transplant in, what happens to the risk? They must have a higher risk of cancer. Well, the short answer is not really. So if you look at this table, this is looking at what's called standardized incidence ratios, SIRs. And it's looking at high SIR, moderate, or no increased risk shown. So if you look at the moderate and the no increased risk of common cancers, and again, this is looking at the risk post-transplant, so patients who underwent a transplant. Things like lung, colon, cervical, stomach, liver, breast, prostate, rectum, there's no or moderate risk increase for these cancers post-transplant. So the transplant immunosuppression has very minimal effect on these cancer risks. So the post-transplant procedure essentially for these patients is you just screen them as you normally would. So if they're due for their colonoscopy post-transplant, get it done. If they're due for their pap smear, get it done. If they're due for the mammogram, get it done. The cancers that have the higher SIR or standardized incidence ratio are actually the more kind of unusual things, right? Like the lymphomas, the Kaposi sarcoma, thyroid, small intestine cancer. Some more of these sort of rarer cancers that there's really no screening for, right? No one's screening for thyroid cancer necessarily, right? There's no testing for that we're doing. So it's more of these sort of unusual things. And certainly, as you know, skin cancer is probably one of the more common cancers that we see, particularly squamous cell or non-melanoma post-transplant. That is one that we do screen for by sending our patients to the dermatologist annually post-transplant for annual skin surveillance. So how do we screen on the front end? Well, frankly, we just follow the national guidelines. We don't do anything special. So if they're due for their PSA check, we check their PSA. If they're due for their colonoscopy or their non-invasive colon cancer screening, we get that done. They're due for the mammogram, we'd like to make sure that's up to date. Renal cancer, our patients do essentially undergo de facto screening for renal cancer because all of our patients get a CT scan of their abdomen and pelvis to look at their vessels. So all of our patients essentially get renal imaging done. So we do screen for renal cancer, although I don't think you need to screen everybody for renal cell cancer, to be honest with you, but we do kind of by default just because we get abdominal imaging. So we do look for that, and we do look to see if any patients have masses or anything on their native kidneys. As you know, patients on dialysis have an increased risk of acquired cystic disease, and those cysts can sometimes become masses over time. We have instituted a few years back lung cancer screening, so you probably know about this. This came out of a New England Journal paper that came out a few years ago. So patients with high risk, so long-term smokers are the primary recipients of this. They do get a low-dose chest CT to look for lung cancer screening. Other cancers that we screen for, well, if a patient has a history of skin cancer, we're certainly going to send them to the dermatologist for clearance. We make sure that their pap smears are up to date. If they have anemia out of proportion to the EPO they're receiving, or if they keep needing transfusions despite getting EPO, we often will do an SPEP or a UPEP to look for myeloma or some kind of other hematologic malignancy. If that's really worrisome, we may send them to hematology for clearance and maybe even a bone marrow biopsy. That doesn't happen very often, but it is something that's in the back of our mind in these patients who have anemia out of proportion to the renal failure. And then sometimes patients need additional imaging. If they have a lung nodule that we find in the base of their lungs when we do their abdominal CTs for their kidneys. Then sometimes they end up getting a full chest CT just to look to see if they have any other nodules or anything else going on in the lungs. So a lot of this, though, becomes at the discretion of the physician that's seeing them at the time and based on the patient's history. But much of what we do, honestly, is all protocolized and kind of done by checklist. And our coordinators on the pre-transplant side have a checklist that they essentially follow and have the patients get all these tests done before they actually see us for that readiness visit. So our goal is when they come in to see the doctor for that readiness visit, all, if not most of this has been done. So the doctor is basically in a position where they can review this with the patient and make sure everything, as I said before, is kind of wrapped up in a nice little bow and tidied up so the patient is ready to go for transplant. So 7 months after readiness visit, JM gets his offer. He gets called in by the coordinator. He tells the coordinator that he's not had any hospitalizations or any medical problems since he was seen for that readiness visit. He comes into the hospital. Nothing needs to be done. He essentially goes right to the OR, gets his kidney, and everyone's happy, except he has DGF. So we all know about DGF, delayed graft function. I think the problem with DGF is it sort of has this negative connotation and people perceive it as a negative. I will say if you have a low DGF rate at your program, you're probably not doing enough transplants. So if you're sending somebody to a program that has like a 5% DGF rate, I would ask them, what is your transplant rate acceptance? Because I will guarantee you they are not accepting enough organs. So I don't know what the right number is, but I will tell you a very low number probably means you're only taking very, very good quality kidneys that you're giving to just young people who otherwise would get transplanted anyway. So we all know that DGF happens. Our rate is about 1/3 in our deceased donor population. And what is DGF exactly? So the official definition is you need dialysis within 7 days of your transplant. So that's the official definition. So if you read a paper or someone talks about DGF, that's typically what they're referencing. So why does this happen? It's typically the result of what's called ischemia reperfusion injury, right? So you can picture this. You have a deceased donor, say down in El Paso, right? The kidney is being procured. So the kidney is taken out. It may be put on a pump, which does pump fluid through the kidney. It's sitting on that pump, and now it has to be shipped from El Paso to Dallas. So that could be whenever the next flight is, right? So maybe the next flight's not for another 4 hours. So it's been sitting there now for 4 hours waiting. It's got to fly up. That's another hour. It's got to be driven to Dallas. That's another, however long traffic is that day. So you could be looking at, several hours of cold time, maybe 12, 15, 18 hours of cold ischemia time. So now this kidney's been sitting out of the body cold for this period of time. You now put it in somebody else, the recipient, reperfuse it with warm blood, right? So it's getting pumped. Now it gets this reperfusion injury. So that is injury because you had this necrosis happening inside the tubules during the time it was ischemic, meaning it wasn't getting blood flow. Now you're reperfusing it, and now those dead cells are kind of sloughing off, right? So now you have these tubules that aren't really doing their job. They work, but they need to regenerate. So that's typically what you're seeing. You're seeing this ischemia reperfusion injury. So the way many centers used to handle this was they would just keep the patient in the hospital until this recovered. Well, that was problematic because this could take a week, 10 days. I've seen it take 2 to 4 weeks sometimes to completely recover and get off dialysis. So as all of you know now, all of you who partner with us in your dialysis units, we will call you, right? I'm sure you've gotten phone calls from us saying, hi, Mr. Smith had his transplant 3 days ago, but he has delayed graft function. Can he come back to his normal shift with you guys? And I'd say 99.9999999% of the time, the answer I've always gotten is absolutely no problem. Send him back. We'll take care of it. What do you want me to do? And what we then typically will do on our end is every time we see that patient in clinic or review their labs and think there's a new decision that needs to be made, we will call you guys at the dialysis unit and let you know what's happening, give you an update, and also call their doctor, their referring doc who sent them, who's seeing them on dialysis, and try to do our best to partner with you and collaborate with you to keep the dialysis going while we're waiting for that kidney to recover, and then start tapering off the dialysis as the renal function is recovering. And then obviously the ultimate goal is to get them off dialysis completely so you can release that chair and not be held somehow accountable for using a chair for acute kidney injury or whatever. Although you can officially put it down, I think there's a Crown Web category of dialysis in support of a transplant, correct? So I think that's the thing you can put in your dialysis unit. So even though they've had a transplant, you can still get away with using that chair. You don't kind of get dinged for that, I don't think. At least it used to be that way. But so that's how we partner with you guys, I think, to achieve this. And it works very well. This has not increased our length of stay with DGF. In fact, our DGF patients go home same time as our regular patients who don't have DGF. It works very well. And I think, by partnering and communicating with all of you who send us patients, I think has been the real key. And I think the real kind of recipe to our success, because if you don't have that communication, you don't develop those partnerships and those collaborations, I don't think this works. And at the end of the day, doing any transplant is not the work of one person. It's the work of many, many people that go into this. It's not the surgeon that put it in. It's not the nephrologist doing their dialysis. It's not me as the transplant nephrologist, not the nurse coordinator. It's everyone involved, right? It's the person who cleans the room to get it ready for them to come in for the transplant. It's the dialysis tech who hooks them up to the machine at the units. It's you as the nurses in the dialysis unit, the social workers getting them to us for the transplant evaluation. So it's a myriad of people. It's a village to make this one transplant happen. And I think if we don't do this in partnership and collaboration, I don't think it's successful. And I think one thing we've done very well in the last few years here at UT Southwestern is partnering with all of you in the community to make sure we can get these patients transplanted and work with all of you to make it seamless and easy and be there for you if you have questions or need any support. And likewise, you have been there for us when we've needed your help in these situations like DGF. So I do thank you for all of that. I may be over time, I have no idea, but I will thank you and ask if there's any questions.
Thank you, Dr. Wojciechowski. You do have a couple of questions.
Okay.
Okay. First question is, why is amputation an issue? I have a patient denied due to using a wheelchair and not using prosthesis. He works full-time and drives himself to the clinic. He can't use prosthesis due to previous surgeries on his shoulders, and the doctor doesn't want him to risk falling.
Oh, I see. Well, just hearing that, I don't know that would be a rule out. I mean, it's related to functional status. So, so the wheelchair in of itself is not the assessment of functional status. I mean, if this person's working full time and otherwise functional, I would be willing to look at that case. I don't know if this was turned down by us or another center. But, you also have to ask how robust are they if they're not more mobile, meaning, sure that maybe they're driving, but what else do they do? Are they cooking for themselves? Are they cleaning? Who do they live with? Do they live alone? Do they have support? These are all things that would come into that. So I would have to kind of probably see the whole package to understand that particular case. But in and of itself, an amputation would not be a rule out. In fact, we've transplanted patients, like Ivani mentioned, who had actually bilateral BKAs. We have done that because they were otherwise, doing fine. They were functional patients who, had good support. They were still doing all their ADLs, et cetera. So I don't think that one thing in and of itself would be the rule out. There's probably more to it, would be my guess.
Last question. The chart displaying cause of mortality post-transplant appeared to show an increase in, oh, I don't have my thing on, sorry. The chart displaying cause of mortality post-transplant appeared to show an increase in the mortality from malignancy over the years. Why is this?
Yeah, immunosuppression, honestly. Patients are immunosuppressed. As we know, their cancer risk for the common cancers doesn't go up. But lymphoma, PTLD, post-transplant lymphoma, occurs in about 2% of cases. That certainly has gone up a bit over the years with induction therapy, with more potent maintenance immunosuppression. Non-melanoma skin cancer actually is very high risk. It's about a 15-fold increased risk post-transplant compared to non-transplant patients. So there are some cancers that are increased in terms of their risk. And you have to also remember that figure, the percentages are such that, what was causing what. So the infection stuff tends to happen kind of early post-transplant. So in those 80s patients who were dying from infections, that all was happening mostly in that first year. These cancers aren't happening in the first year. They're happening a little later. So the numbers seem skewed because the cancer deaths are happening a little later than the infection deaths were happening. So it's sort of flip-flopped, but you have to remember the event of the cancer is happening not in that first year typically. We're typically seeing that beyond year one. Whereas a lot of those infection deaths that were at high numbers in the 80s were happening early on, right? People were getting CMV at like month 3 and dying because we had no way to prophylax or treat it. So it looks a little skewed.
Okay. Well, thank you, y'all. Let's give a good hand clap to Dr. Wojciechowski.
Thank you, everyone. Thanks for coming.
Thank you. So now it's break time, but I do have a couple of questions that came in about the new applications. These are actually in your handouts. We do have extras here, so if you need to take a handful of them to your clinic so you can give out to your patients, please do that. But on here where the patient signs right beneath it, it tells you where the portal is. So once the patient actually fills this out, tears this off and gives it to you, you can go ahead and upload your documents in the portal, but use the portal and it's here. Our next presenter has provided visionary leadership in the transformation of our kidney and liver programs here. Under his guidance, these programs have seen a substantial increase in transplant volumes, but more importantly than volumes is what? Outcomes, right. So he's actually spearheaded efforts to improve patient outcomes. So please help me welcome our Chief of the Division of Surgical Transplant, Dr. Vadafi.
I got a woo. I don't think Wojo got that. Just saying. Okay, great. Great to see so many people here in person and online. And we'll go ahead and get started so we stay on time. I'm going to go through a little bit about our program and also about what to expect when you're expecting a kidney transplant. So we'll go ahead and get started. So we have a great transplant program here. Our group of surgeons actually staffs 3 different transplant programs on this one campus. So our main effort is at Clements here, our adult liver and kidney programs, but we also staff programs at the Pediatric Hospital Children's, both liver and kidney, and also the kidney transplant program at Parkland as well. And we've had a lot of growth over the last 5-6 years, and both in the kidney and the liver program, and a lot of that has been here at Clements. And you can see that a lot of this growth, it starts earlier in the process, with the referrals, which we're on record pace for this year, over 2,000 referrals, which leads to 1,000 evaluations, and then adding almost 400 people to our wait list, and then they move towards transplant. And this year, it looks like we're going to be 220, 230 kidney transplants probably at Clements, which is a great year, helping a lot of people. A portion of those obviously are living donors, an area that we're looking to continue to expand into and provide more access for. You can see about this year on pace for about 34 of those and 184 deceased donor kidney transplants. And when you look at North Texas, there's a lot of programs, a lot of different options for transplant. And over the last few years, we've been consistently one of the larger programs, and we're on pace this year again to be the largest program in DFW. Again, just the ability to really help a lot of people to get off dialysis or avoid dialysis. So a little bit of the mystery behind all the magic. This is our wait list. If you can see on the screen here, a lot of the growth is obviously building the wait list, but as people get transplanted from the deceased donor list based upon how long they've been on dialysis. And so a lot of our wait list is early. We're getting a lot of referrals early, which is great, get people tied into the system. And then as they spend time on dialysis, if they don't have a living donor, then as their time matures on dialysis, then we get them a transplant. We are able to get people transplanted fairly quickly, probably a little bit quicker than some of the other averages across the region. And that's because we're fairly aggressive with accepting organs, much more aggressive than the national average. We look at every kidney and we give it a good look and try to get people transplanted as quickly as possible. And I think that's one of our advantages here with our surgical expertise, but also our medical and ICU and nursing expertise, the ability to get people transplanted quickly and have them have a great outcome. And then you can see the landscape across Texas, and this is for this year, I think, through September. And the biggest program again in DFW, obviously a couple big programs down south in San Antonio and Houston. But the biggest, actually, deceased donor program in Texas. And again, as we grow our living donor program, we're hoping to move on up and claim that top spot over the next few years. We're always looking at ways to expand our reach, and at the end of the day, we want to help as many patients as possible. And we have a lot of different examples of that, whether it's our clinics in Lubbock or in Tyler, but even in Dallas. And this is one example, and I think it's appropriate given it's Veterans Day is coming up next week, and is really, we've been working for a few years now to develop outreach with our Dallas VA for both liver and kidney transplant. If you guys know a little bit about veterans, traditionally, if they needed a transplant, they would have to travel to Houston or Nashville to get a transplant. There were some changes in the laws a couple years ago, allowing them to gain access to transplants locally. And we want to be there to be that center for the veterans in DFW. And so we've worked with our colleagues at the Dallas VA in, not only giving access to transplant for, these heroes that are living in DFW, but also making it easier for them so they don't have to travel. And so you can see this is a program that, the numbers aren't huge, but they're still very important to us, and they continue to grow. You can see that we're getting a lot more referrals, a lot more people getting added to the list, and already this year we've done 7 kidney transplants for patients, for veterans in DFW. And so this is something we're really proud of, and we hope continues to grow. Again, we're at Clements, which is a beautiful hospital, and there's a lot of great stuff going on. But one of the things that really, I think, sets us apart is really that we, don't avoid the complex and complicated. That's kind of our bread and butter here. And so not only do we want to transplant a lot of people and do a great job at it, but we want people to look at us as that resource to do the toughest cases. And a lot of that is doing multi-organ transplants. And so, we have great thoracic transplant teams here, heart and lung. And so we work closely with them as well as the liver team in being able to really deliver quality care. We're one of the larger programs in the country for doing combined liver kidney transplants. Again, working hand in hand across disciplines to really deliver that kind of care. Again, heart kidney transplants, again, also, top 20 program in the country. We do lung kidneys. Again, these are kind of the handful of the same 20 programs maybe across the country that really take on these really challenging cases. We even have done a heart, liver, kidney transplant. Very rare, but that's the kind of expertise we like to provide. Heart, lung, kidney transplant as well. We've done, you can see only 5 places in the country have done one, and we're one of them. And so I think that helps distinguish us, just as that being that kind of resource for our community. As I mentioned, we have, we try to do outreach and get our team out to patients, not just to, the transplant care is going to be provided here at Clements for that operation, but we try to bring all the rest of the stuff closer to people's homes, whether that's through virtual visits or our outreach facilities. And so we have clinics in East Texas, as well as out in Lubbock, where we can set up shop, and the nephrologists actually rotate through. And so there's a continuous presence there. We collaborate well with the referring providers. And so really, so patients are going to get most of their care close to home and just have to come in for a short 3-day visit to get the new kidney. And then most of it is then done back at home. Again, living donation is obviously an area we want to expand in, both kidney and liver side. And this is, we utilize Breeze, which hopefully makes it easier for people to talk about living donation and have donors evaluated. And we'll look at as many donors as it takes to find the one that's the right match. And so this is something that we're very invested in. And I think you're going to hear, you already have heard some about that, and you're going to hear more about our living donor champion and all the work that she does in helping people get transplanted. A little bit about the outcomes. these are, available online. You can look at any program's outcomes, but you can see that this is the volume. These are all the transplant programs that do kidneys in the country. This is the program volume for this time period examined. And then we look at the hazard ratio, and if you're above 1, you should be concerned. If you're below 1, you're doing well. And you can see we're well below that 1 bar. And we're a moderate-sized program across the country. And even our 3-year survival, you can see we're well below the 1 bar and have good volume. And so, and that's important to us. It's just not about doing a lot of transplants, but it's about, the outcome for the patient, right? And not just a short outcome, but a long-term outcome as well. And you can see this is our, dark blue is our 1-year survival here and our 3-year survival right next to it. And the light blue is where we're expected to be based upon our recipients and based upon the type of donors we use. And you can see we exceed what is expected of us. In fact, if you look at our 3-year survival is higher than most programs' 1-year survival across DFW. And so I think that's important because it's just not about the surgery, but it's about all those visits afterwards with our nephrologists and our APPs in the clinic and maintaining that kidney for as long as possible. And, we want people to have a good experience, but we also want them to get home as soon as possible. And you can see that now for over 5 years, our length of stay has been well below the national and regional averages. So people are in the hospital, whether you get a living donor or deceased donor, you're going to be in the hospital for, on average, for 3 nights. And then if you look at across the country, of all the programs that have like a 3-day length of stay and are doing, a sufficient over 100 kidneys a year, we have the best survival of any program in the country. So again, metrics that we're really proud of and really take a team effort to achieve. So, we like having a big program, but we also want to have value. And so we talk about not only have a high volume, but good quality, but also reduce the cost for everyone, for the patient, for the system, for the payer, so everyone. And so we also recognize that the value really helps drive our academic mission, research, and education. So those are important to us here as well. And so that's, whether that's, training fellows, surgery fellows, nephrology, hepatology, we have all these, APPs, med students. These are the future of transplantation, right? These are the ones that are going to be taking care of us. And so we're really committed to that effort. And you already heard about the research piece, I think, as well. But so we're hoping to, COVID slowed us down a little bit on starting a pancreas transplant program. We're hoping to get that going in 2024. Again, we're looking to expand our living donor volume and continue to provide cutting-edge care for our patients through clinical trials and partnering with our partners in industry and really try to, develop the future of transplantation for all these people who are waiting. We have a great team, a lot of great nephrologists, a lot of great surgeons as well that help get all the work done, and APPs, and a lot of coordinators that help support all the patients, both pre and post-transplant. And so everyone in administration, social work, I hope we didn't leave off anyone because that's a big list there. So TFCs, dietitians, everyone. So it really takes a village to get it all done. Thanks.
Thank you, Dr. Bagafi. You have one question, and it was, do you ever do like a mini tummy tuck when you're in there doing a transplant? Okay, that didn't come from the audience. That was from me. So that's it. No questions. Thank you. Yes. Okay, so next up, our next presenter, of course, we have a treat for you. Our next presenter has over 20 years of healthcare experience. He believes in honoring life through donation and is joining us here today. Please help me welcome Doug Butler. He's the COO of Southwest Transplant Alliance. Welcome.
Excited to be here today. Again, Chief Operating Officer at Southwest Transplant Alliance. So we are the Dallas-based organ procurement organization, and there's 3 organ procurement organizations throughout the state of Texas. So we service not only Dallas, but all over far east, far west, far south, and everywhere in the middle. And I'm going to talk to you a little bit about the OPO perspective and kidney discards and all the things that really go with that. Overall, we know that kidney discards from the deceased donors is a continuing problem, and we're seeing throughout the nation about 25% of deceased donor kidneys are discarded. And some of them, and I'm going to dig in a little bit about that, and more interesting enough, there's a higher percentage in Texas in this region. We call it Region 4, Oklahoma and Texas. So we as the OPO, as a supplier for Dr. Vagapi's programs and many of the other waiting recipients and programs, we have a responsibility to optimize donation and maximize donation under every deceased donor circumstance. So I'll dig a little bit more into that. But first off, not to get too in the weeds, but we deal with death and dying day in and day out. And it's not easy, but that's the reality of how we transplant patients in many of these circumstances. So I really would just want to point to, we work with our teams on a culture of joy. Also, every single opportunity for donation is a catalyst for us, that catalyst of donation. And also, sort of like Dr. Vagapi talked about as far as that research, innovation is important as well in the organ procurement space to not only see those complex donors, but also what technology can we use to not only prolong the organ for transplant, but also maximize and improve outcomes in donation in general. So I'm going to dig in a little bit about each category here. We're going to talk about allocation, some cold ischemic time, the importance of it, these complex patients, biopsies, and a little bit about DCD. But I just want to hit on that continuous distribution has changed the landscape of donation, and I'll dig a little bit into that. So originally OPO started based off of a transplant center need, and we had tight regions, and this has expanded as our industry has expanded overall. So we realized at a certain point we could ship kidneys further, we can ship hearts, we can ship all that, which led eventually to broader sharing. So now we're sending, as the organ procurement organization, instead of sending it down the road to, say, Clements, we're sending that same kidney to New York or California. And there's some difficulty there. And what we saw as an organ procurement organization, specifically where we're at, is a negative impact on our placement of organs. So we had to do something about that, and I can explain a little bit more about that. We've also noticed an increase in the volume of calls in the centers. Obviously, it is a full-time times 10 job to take referrals. Organ procurement organizations are trying to maximize donation. You have a landscape where calls are coming in throughout the whole country, and you have a finite number of resources to take those offers. So it's been a really, really hard thing for the whole system in general due to some of this. And we are also seeing a lot more travel. So where we used to go down the street, we were flying to New York, and we're actually flying over each other a little bit. The advantage of it is it's getting some of those patients, those disadvantaged patients in certain areas, transplanted. So there's value to the system, but it does increase the complexity of allocation in general to where our average length of time for a deceased donor case used to be about 1.5 to 2 days, about that 36, 48 hour mark. And we're seeing this with that increase, that broader sharing, it's going 2 to 3 days in some cases. So the organ donation, deceased organ donation process has gotten a lot more complex due to this. And on the transplant side also, when we're sending out those offers, it goes to tens of thousands of patients sometimes. So we're having to navigate through all of that. Well, centers have the access to say, we won't take that particular kidney. So there's an offer filter function. And again, the time, the distance, and all of that has gone up. But again, it's getting certain patients transplanted that previously wouldn't have been transplanted before. So there's some advantages there. But from an organ donation, organ procurement perspective, it has increased the complexity. And almost the 2 decades of doing this, there's been more movement and more technology over the last 2 years than I can ever remember. And part of this is recognizing the system isn't perfect, also recognizing as an organ procurement organization, we have a responsibility to get the right kidney to the right patient. And that is not as easy as just a list sometimes. And in most situations, we go down that list and we find a patient that's accepted and we move on. With this allocation, it's caused us to have to look at things a little differently in more of the medically complex kidneys. Many of our patients, way back in the day, we used to have the perfect donors. Our donors now extend into 70s, 80s sometimes, and they're medically complex. They have liver disease, they have other comorbidities, which are leading us to have a hard time placing that kidney. But you can find the right patient. It just takes getting a little creative. And this is something that OPTN and UNOS has acknowledged, that there has been some bypassing in these situations, but it has led to more organs being utilized. So overall, we in these complex situations try to find the right patient. And what that means is we want these organs to stay close to home. We do, so we go through our Texas centers first, and after we're done there, we go nationwide based off of UNOS data to see what centers will take a kidney under these certain conditions. So what it's done for us is our previous discard rate for kidneys was around 27%, and we see about on any given month about a 5 to 7% reduction. But it's a lot of times going to a patient way down the list because it's the right patient for that right organ. So it's sort of a blended approach, and this isn't in any case. You look up here, a lot of words up here, and it is basically related to older DCDs and older brain dead donors because these are more of those patients that are medically complex, and these kidneys are harder to place. And it's not about the 21-year-old brain dead donor. It is more about the 55-year-old patient that has hypertension, diabetes, and is a DCD. How can we get that kidney placed, and who should that kidney go to? And I think Dr. Fogg, I'm glad he went before me because they really pride themselves on medically complex transplants, right? And that's sort of that partnership there that we work with them on to get that kidney and have the right team to be able to support these more complex cases. A little bit about kidney pumping. So something we do as an organ procurement organization, knowing that a lot of our kidneys will go far away, or even helping the local transplant teams to be able to transplant these organs in the morning versus the middle of the night, is we provide kidney pumping, and this is a hypothermic device. It's been out for quite a while. And previous to that, we were, a few years ago, just sort of gauging what kidneys we would biopsy. The best thing that we can do for a kidney is extend its time. And that's really what the kidney pump does. So any kidney with a KDPI or the kidney score above 35, we just automatically pump them. And if it's below 35, we'll do it upon center request. Again, these cold ice versus pumping, it extends and it can send out up to 24 hours versus just having the organ on just ice in general. So we, on our part, are doing everything that we can to try to increase the viability of all these organs, all these kidneys for transplant. So something we've seen as well, and I mentioned a little bit earlier about what the typical donor looked like before. And even 10, 15 years ago was a brain dead young donor where we were likely going to recover at least 3 to 5 organs on that patient. Anymore, we are pursuing donors that have any type of viability whatsoever to transplant a minimum of 1 organ. So we were looking at every organ system. These donation after circulatory death, we're looking up to 70 years old because they're being transplanted now. Medical science has advanced so much in the healthcare teams, and it's just amazing to see where healthcare is going. It's allowing for that to happen. And there's certain technologies I'll talk about further in the presentation to where there's no ideal donor anymore. So from the organ procurement side, when we get the referral from the hospital, we automatically go every single time, and we in-depth evaluate every single patient and every single organ system within those patients to make sure these patients, on the transplant end, we're saving patients on the wait list. And this has led us into different areas of even patients prior to this brain dead donors had to be neurologically compromised. We've had ALS patients request to be donors and become donors. They self-authorize, and so these boundaries that we've created in the past are eroding because there is a dire need to transplant these patients on the list, and we don't want anyone to die waiting. And even these very, very complex ECMO patients that come in and they're put on the ECMO circuit after a cardiac arrest and they're having organ function issues, we pursue those donors with good success. So just the landscape has completely changed. Another thing too that's requested a lot of times in part of protocol is kidney biopsies. And kidney biopsies are one little piece of the pie, and what we say, and this is my own opinion, they're consistently inconsistent. We'll have two kidneys in the same body with the same patient, and one biopsy is drastically different from the other. It's one little piece of the pie. So what we do from the OPO perspective is we've aligned with Region 4, and now there's national policy we realized we over biopsying kidneys, creating this sort of false view of this kidney when everything else sort of looks good. So that actually impacted the kidney discard rate at all. So those sort of patients we're pursuing, those marginal ones, those are the ones we're biopsying, not the younger patients, because the literature has really shown that the outcomes are similar minus the biopsy. So. And just a little bit about Southwest Transplant Alliance, and I'll go through here. And this is, as we look at our growth and every potential, and we're, number one, it starts with the hospital referral and having great partnership. And Scott's been a great partner to help, and we have a hospital service associate to help make sure we identify every potential. So you can just see we continue to up the potential. And as the potential goes up, some of these are more complex cases. So our authorization rate really hangs around at 55%. But if you can just look at the increase in donors is increasing overall transplants. And then on the far right, many of those are in the donation after circulatory death category. Again, some of these meaning that they are not brain dead, and the family has opted for withdrawal of life-sustaining therapy. So if they die within an allotted amount of time, we do a rapid recovery of the organs. So leading to more transplants. And again, you can see, and I know we're focusing on kidney, but I just showed everywhere else, how it is directly impacting the increase in kidney donation. All of these things that we're talking about, the inefficiencies, along with the aggressive pursuit of these donors and also medical science supporting all of this to really grow and provide transplant centers with organs. And just some cool sort of stuff. It's not a neat video like Dr. Bagafi had, but we've engaged in a project regarding rural healthcare. And one of that kidney center that he previously said in Lubbock, that's one of the main areas that is piloted from. One of the biggest issues is rural healthcare and the access to healthcare. And that's something we're partnering with this consortium to help figure out. And even if it starts with just getting blood samples here or getting medications out to Lubbock and rural areas in that area, it's improving the system. This is way down the road. This is going to take a lot of infrastructure, and it's, y'all seen in Maryland, I think it was, a kidney went from one building to another. We're a ways away, but it's another innovative way that we are trying to support rural healthcare in general and the access. So it's sort of a cool thing, and they actually have figured out railways and telephone lines are okay with the FAA to travel on. So there's been studies and there's been different things that have gone on there. Pretty cool sort of something. Normal thermic regional perfusion. That is a technology that's been utilized more in the last couple of years. And essentially it is on donation after circulatory death, DCD patients. After they pass, the organs are put on a pump to circulate, sort of like an ECMO pump, to circulate blood within their organs, which is leading to more transplants overall. It's leading to more transplants. It's leading to better outcomes, reduced length of stay. And so this is something that's really taking off throughout the donation community in general. But overall, it's a technology that's being utilized to increase transplants. And that is it. So I wanted to stay on time. Thank you.
Thank you, thank you, thank you.
Yes, any questions?
We have no questions that's come in. Anyone in the audience have a question really quick? Doug, can you repeat that question for the individuals at home?
Oh, I'm sorry. There was a question about the older patients up to 70 and how essentially we match those patients up. And it's really through the list through UNOS and what the transplant centers are willing to accept. So the question is there an advantage to dual listing a patient? And I hate to not answer that question, but that's more of a transplant center related question. I can see, obviously, there's data out there in patients being well informed on how to list themselves. And I think there's a lot of programs to help advise patients on the best listing practice.
Thank you. I believe that's it.
All right. Thank you all.
Now we're in the home stretch. And I have a treat for you. His name is Mr. Scott Bennett, and he's coming up to close us out this afternoon. He's actually my boss, so be good to him so he can be good to me. But Scott, go ahead, take it over.
Thank you, Yvonne. I'm here to land this plane, so let's do this. I want to get you out on time. But thanks again for your attendance today, your attention. You've asked great questions and engaging our team, and we can't do it without you. You're an important part of this partnership. You remember the complicated subway system I showed earlier? We're all a part of that. Doug and the OPOs included. We all have to work together to make this complicated system work. And to that point, it is working. So if you look at the last 10 years across both the United States and Texas, you see two good numbers trending, right? What do you see? Kidney transplant waitlist additions. We're getting more people listed and more people transplanted. And fueling that is more donors also that are helping those patients to get transplanted. So what I have to say in conclusion really is keep up the good work. Let's keep working well together and getting more patients transplanted. If you continue to have questions after the program, I'll point you back to Yvonne. She's been a wonderful moderator today. Give it up for her again one more time. And of course, Helen Bankston, our intake coordinator. Those two are a dynamic duo. You saw the growth that Dr. Vagavi showed earlier. Those two ladies have felt it, I know. And they do a great job in taking great individual care of those patients despite the great numbers. So in conclusion, thank you again for attending today. We're all here to give that gift of life to our kidney patients in our population that we serve. So thanks again for your partnership. Drive safe, and we'll see you next year.